Executive of Services Institute of Medical Sciences, Lahore, and respected Dr. Afzal Alam, Consultant Audiological Physician, and respected Dr. Daniel, Co-founder and Director Administration of Family Educational Services Foundation, Lahore. We are honored to have you all. We start our program with the recitation of Holy Quran, and for the tilawat of Holy Quran, I request Hania Razak, our final year student, to recite few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر صدق الله العظيم.
Jazakallah. In this scientific symposium, we will have enlightening sessions related to nutrition and hearing from our renowned experts. For the first session related to nutrition is focused on obesity, which is a form of malnutrition, and globally there is a rising trend of overweight and obesity. In Pakistan too, we are facing triple burden of malnutrition. We have wasting, stunting, and along with that, we observe rising trend of obesity. To enlighten us about obesity and its associated consequences, I may request Dr. Tabitha Dogal. She is a consultant endocrinologist with a special interest in obesity, transition endocrinology, and female endocrinology, and he has vast experience in nutrition during pregnancy. Please warmly welcome Dr. Tabitha.
I promise I'll be less boring than you think. Just to introduce this new concept that everybody knows about obesity and everybody knows about malnutrition and how they can coexist. I just wanted to introduce this concept. So, once upon a time, hunger was just a one-dimensional, unidimensional thing that there were places that didn't have enough nutrients and people were hungry, and there were famine areas and we provided them with nutrition. And they were usually areas of low income or war zones or people with difficulties in trade and things like that. And then you provided them with food and that was all right. So you would see things like this, and you still do, but there are several concepts that feed into hunger and poverty, and all that is part of that. So you've got wars and conflicts, and you've got poor governance, and you've got unfair global trade and social insecurity and things like that come through that will cause all these things. But increasingly we see that hunger exists side by side with obesity. So basically what we have to do is when we feed someone, we have to provide them with quality nutrients that don't put on weight, but at the same time provide nutrition. So you really can't fix hunger by just feeding people. You have to give them quality food, which is nourishing food, which has micro and macronutrients, and hence the concept of obesity malnutrition. So this was a new phrase coined by Lancet, and it was spotlighted in there, and it's just told about this new concept or this dual problem of undernourishment and obesity coexisting So it is called DBM, the double burden of malnutrition. So not only are they malnourished, they are also big in size. So hence, at the same time, they are also exposed to the risks of obesity as well. So for example, this child on the right-hand side is malnourished currently, but when he grows up, he has got access to food which is low quality, but rich in carbs and rich in sugars and fats, and he will be obese, he'll put on weight, but he'll still be malnourished. So he's malnourished and will stay malnourished. So an estimated 2.3 billion children adults are overweight, and about 150 million children are stunted. So there are more people who are overweight than underweight right now. So this is a huge problem, and in them this phenomena coexists. So unfortunately, when there was a census done in 2014, Pakistan rated among the top 10 countries with obesity, adults and children alike. And I will give you some figures later on. So basically, what we have seen is a seismic shift in how people spend and how people have done their daily chores like washing and cleaning and all those. They are now machine oriented. People don't walk to places anymore because of many issues, because of safety. There are very few playgrounds for children, and there are very few schools that cater for those kind of activities. And hence, the expenditure of energy has kind of reduced. People have more disposable income, and people are spending more on food that they would like to eat, whether it's good food or not. It's convenient food and they just eat it. So basically, the study that I want to show you was really shocking, and I was myself quite shocked with it. Was actually showing, it took a lot of studies on board, and it had about more than 62,000 children in it. There were 51 cross-sectional studies. And the kids were from ages 5 to 15, and the indices measured are there, you can read them. And basically the data was also supported with their socio-economic background as well, which is again quite sad, but it gives us an insight into how the other half lives. So basically what the results were, they were underweight children, and they were about 25%, so 1/4 of them were underweight. They were wasted, so they were extremely undernourished, 24% of them were. And they were thin, they were 12.5%, and about 20% of them were either overweight or obese. So basically, out of all those, out of 100 kids, only about 17 were healthy. The rest of them were either under or overnourished. So you can see 1 in 5 kids is overnourished, and the rest are not. And these people are actually malnourished, although they're overnourished, but they're malnourished. So sadly, again, as I said, you saw that people who were of the lower socioeconomic class, females, or were from areas that had been disadvantaged by natural disasters, they ranked in the undernourished strata of the study. The reality is that we need to eat good food, which is good with vitamins and minerals, and also has got fiber and cereal and all that. But most of the globe has developed this habit of eating bad food, which is bad choices in food, which is rich in fat, carbs, and refined sugars as well. And 2 big culprits, as you know yourself. So basically, what we need to do is, and the main reason for talking to you is because you're all young people and you have the ability to change, and then you know, in some years you will have your own kids, and basically what we have to do is we have to be examples for our own children, and that's where we make the change, that's where we bring about the change. So basically what we have to do is we have to base our meals on high fiber and high starch. Basically it has to form about 40 to 50%, and that starch has to be full of fiber, and it hasn't got to be refined starches. So they have to be high fiber, like full, like grain which hasn't had the husk has not been removed, like potatoes with their skins on. And basically, because we know that proteins are base of carbohydrates, we have to be aware of the hidden fats in parathas and naans and all those things which form the basic architecture of our everyday meal. And we know that we need 5 a day of fruit and vegetables, which I would suggest, although people would say 3 fruits and 2 vegetables, I would say reverse that. So have 3 vegetables and 2 fruits, mainly because, you know, we as a race are more prone to have diabetes. So every fruit has got fructose in it, and with the fructose you change it to glucose, and you would have higher risk of having impaired glucose tolerance. So having more vegetables which have more fiber in them instead of fruit would be better. So 2 portions of fruit and 3 of vegetables would be much better. So also Also, these are various techniques with which you can improve how you eat your meal and how you can swap things for things with more fiber in them and vegetables and fruit as well. And you know, vegetables are our friend and we can do many things with them and you can kind of, you know, sky's the limit no matter how many ideas you can put into the vegetables, they're good. So I see that the trend is towards more and more towards meat and I see people are eating meat every day. So the recommendation is that no one should eat more than 70 grams of red meat a day. 70 grams is one chatan. So how much is one chatan? Like this portion. And I see people eating huge amounts of meat and every day households have meat cooked in them. Less chicken and more meat. And I would also suggest that you consider fish to be part of, you know, protein and legumes and as well as milk and milk products like cheese and yogurts to have some protein rather than relying on meat alone. Also, all these things have got saturated fats in them, like meat is full of saturated fat. The recommendation for women is only 20 grams a day, for men it's only 30 grams a day. So also mind the salt that we put in our food, it's only 6 grams, which is very small amount. And also beware of putting salt in all the food that is prepared or the food that we buy frozen and all those and frozen vegetables as well as frozen items of food that we fry at home. And fiber is our friend, so always make fiber your friend, 30 grams a day at least, wherever you get it from. And a shocking truth is that there are more deaths being caused by poor nutrition rather than smoking. So smoking isn't killing as many people as poor nutrition is. So this is really a wake-up moment for all of us, and we really need to concentrate on our diet. So basically, it's not my opinion, but I agree with his opinion, is that Will Masters said that, you know, you cannot rely on people to make good choices, and therefore legislation has to come in for people to rely on that, and so that all the bad foods are under legislation and they're not being served. So basically, because the food vendors and people who provide food in Pakistan is so diverse, like from a single vendor on the road who might be doing it from his dairy to a big factory, it's a very diverse diaspora of people who are providing food. It's difficult to police them, but I think it's still doable. We need policy changes, we need policing, we need food hygiene, we need their training, we need upskilling. We need to make sure that they know what is good food and how to serve good food and how to serve, you know, hygienic food as well as nutritive food. As regards as getting hold of good food, I think people who are growing food, the farmers, they make up 60% of the population. They should be helped to grow vegetables. They should be allowed not to waste too much food, and they should also be allowed to sow new grains which require less water. As we know, the water table in Pakistan is dropping, so things like sorghum or buckwheat has got a lot of protein in it, so as a grain it's very good, although it's a kind of wheat, it's ancient, these are all ancient grains that were there, you know, in ancient times, but they're all good. They're good with fiber, they're good with glycemic index is quite low. So the farmers need to be facilitated, they need to have access to seeds and fertilizers. And we really need to rely on some nutrition impact group, which I want you to be part of the nutrition impact group, whether you are the nutrition impact group in your home, in your locality or in your class, or we need nutrition impact groups. So this is Jamie Oliver, who's a famous chef in the UK, is also known as the Naked Chef. So he brought about the revolution in the children's school food. So he banned all the chips or the fried food that was being served to the children. And he worked with the parents and he worked with the government and he brought about this revolution sort of in kids' school meals. So the school meals completely changed forever. So you won't get the stodgy lack of nutrition meals for schools in the UK. And this is Michelle Obama. She also did the same thing. She also did a lot of work with the school children to improve their school meals. And lastly, also to say that we know that breastfeeding stops obesity and type 2 diabetes in future years. We should also lobby for reducing sugars in the drinks and soft drinks that are available. Also, the unhealthy foods in the UK are now in the back aisle, so people have to travel through the store and then go to the back aisle, and they might change their minds walking to the bag of crisps or to the bag of chocolates. So therefore, I think all the unhealthy foods should be at the back of the store rather than being at the front. Kids buying them or at the checkout, they shouldn't be at the checkout. So we've we've got that, we've stopped having that since October, so we don't have them displayed at the front. There should also be increased tax on the fast food and things that are injurious to health, and we all know what they are. Also, I think, as I said, they have stopped using the front to display, and this is one of the stores. You can see all the bad goods at the back. And I think the way to get started is to quit talking and begin doing, and I would expect all of you to start from today. So I thank you with all this, and this is my email address if anybody has any questions.
Thank you very much, Dr. Tavinga, for a very enlightening talk about the topic of which is the need of the hour. Food choices do matter, and we have poor food choices not only in low socioeconomic status people, but people belonging to higher socioeconomic status also have poor dietary habits. Thank you very much, Dr. Tavinga. For the next session, I will request our Pro Vice Chancellor, Professor Shamsa Humayun. She is the chairperson of Ops at Gynae FJMU, and she also is the president of Association of Ops and Gynae. And she will talk about a very important topic as if the malnutrition left unaddressed, especially in young girls, it can catalyze an intergeneration cycle of malnutrition, and Madam will highlight about the intergenerational injustice. Please, Madam, enlighten us. Respected Dr. Tavinga Dogar, President Canva, Professor Farooq Afzal, Principal, Services Institute of Medical Sciences, Professor Yasun Nabi Tayyab, Dean, Faculty of Endocrinology, Dr. Afzal Alam, Audiology Physician, Mr. Daniel Luther, he is Director Operation of Deaf Reach Program. Ladies and gentlemen, Assalamu Alaikum. It's my proud privilege to be part of this annual symposium organized jointly by CAMCA UK and Fatma International in lieu of this international conference of Fatma Medical University and Fatma Alumni APNA. Thank you, Dr. Tavinga, for making my life easier, as I am going to draw your attention towards an issue which is not only affecting lower and middle income countries, but also hitting the people living in high income countries, though with in a different manner and with different consequences. So, here I would like to share with you two scenarios. Mrs. R is 22 years old, primary gravida, presented for booking at 16 weeks of pregnancy. She is pale, weighing 45 kg with BMI 16 kg per meter square. Mrs. KR is 30 years old, gravida 4, para 3 at 18 weeks of pregnancy with history of gestational diabetes. Her weight is 90 kg with BMI is 28 kg per meter square. These are two women, and let's see. In one scenario, the lady was underweight and the lady was overweight. So weight is not the parameter of measuring the nutrition. So malnutrition is deficiency or excess of nutrient intake. It can be imbalance of essential nutrients, or it can be impaired nutrient utilization. So all these three, they are categorized as malnutrition. So as Tavinga has said, it is a triple burden. I think it's triple, rather more than that, but how it is double or triple burden, it not only affects the health of the individual, but it also triggers the diet-related non-communicable diseases which we are seeing more and more, like dyslipidemia, hypertension, glucose intolerance, so on and so forth. Unhealthy diets are one of the leading causes of global malnutrition. How? The evidence shows that 1.9 billion adults are overweight or obese, 2 billion suffer from some form of micronutrient deficiency, and 161 million children under age are short of the height, and 795 million people, they are eating what they should not eat for living. So this is the magnitude. As I am chairperson and head of obstetrics and gynecology department, and I am an obstetrician and gynecologist, so I will focus my talk on malnutrition in pregnancy. It not only affects the health of mother, but it alters intelligence of the newborn by interfering with energy level, rate of motor development, and overall health in adult life. So, the topic of my talk is malnutrition and intergenerational injustice. So, which women they are at high risk? The seeds are sown before pregnancy. It's young girls, adolescents who are anorexic, bulimic, underweight, or overweight, obese, vegetarians, smokers, and if during pregnancy they suffer from excessive nausea, vomiting, with pre-existing medical conditions, they are more prone to become malnourished. Here you can appreciate how malnutrition or wrong diet, imbalanced diet before pregnancy influence the health of women. If there is an insert before pregnancy, it will impair fertility. During pregnancy, high risk of repeated pregnancy losses. It triggers gestational diabetes, preeclampsia, and story does not finish here, as those women who are malnourished, they have difficulty in initiation and maintenance of lactation, hence doing a disfavor to their newborn. इस साइकिल को मेरे साथ देखें. So this is the cycle. आपने teratogenesis का तो पढ़ा होगा, but I am going to coin two new words. Nutrient-mediated teratogenesis and fuel-mediated teratogenesis. यहाँ से देखें. If the mother is undernourished, she will enter in pregnancy with impaired fetal development, so she will deliver a low birth, thin fat phenotype newborn, and if not, intervention is not done, an undernourished child will become an undernourished mother. Similarly, there will be the long-term consequences of decreased muscle and bone mass, stunting, increased insulin resistance, and last but not the least, poor cognitive ability. The fuel mediated, आपने ज़्यादा fuel pump कर दिए हैं. There will be insulin resistance in pregnancy, gestation diabetes, altered fuels will go to the fetus, release of more insulin like growth factor and macrosomia. Long-term increased insulin resistance, dyslipidemia, inflammation, diabetes, and coronary vascular disease. So, one generation affects the other generation.
दिस इज वेरी इंटरेस्टिंग। वो कहते हैं वजन काम कर करके थक गए, वजन ही नहीं काम होता यार, भूखे रह रह के भी थक गए। सो दिस इज हाउ दे आर प्रोग्राम्ड। अर्ली लाइफ न्यूट्रिशनल इंसल्ट्स does the fetal programming affecting hypothalamic pituitary ovarian axis and sensitizing appetite regulatory genes. Hence, the newborn will suffer with metabolic disorder, obesity and diabetes. So mothers to be blamed. Now, nutritional status in Pakistan. वो तो हमने एक जनरल बात कर दी। The nutritional status, 50% of our young women, they are anemic. 38% are iron deficient. Vitamin A deficiency is equally prevalent along with micronutrient deficiency in the form of zinc, calcium. Hence, ये थोड़ी सी स्लाइड डिम है but बड़ी इंटरेस्टिंग है, that inadequate mother who is unable to supply nutrients according to the fetal demand and fetus is undernourished, what happens? Inadequate building blocks, less nephrons, so the newborn will be more prone to develop chronic kidney disease or CKD in adult life. Similarly, the liver formation will be affected, having decreased insulin sensitivity, so diabetes. Similarly, decreased beta cell formation, less secretion of insulin, again glucose intolerance, decreased muscle and bone, increased fat. सबसे बड़ी बात है, ब्रेन और हाइपोथैलेमिक पिट्यूटरी ओवेरियन एक्सिस adapts itself to the reduced need, to the reduced supply of the nutrients. So all this, they take their toll on the newborn in adult life. Hyperlipidemia, hypertension, central obesity, insulin resistance and type 2 diabetes along with coronary heart disease are the consequences of malnutrition during pregnancy. अब ये देख लें बच्चे में क्या इफेक्ट हो रहा है, तो हमने मदर पे इफेक्ट देखा था। So during pregnancy, if there is under or overnutrition, there will be impaired growth and development of the fetus, impaired metabolic and immune programming, and more prone to have neural tube defects. The newborn baby will suffer with lower excessive weight gain, impaired growth and development, poor cognitive development. Similarly, as an adolescent, there will be more fat accumulation, short height, and more risk to various forms of cancer. Adult life. ये देखने यहाँ का insert यहाँ तक जा रहा है, and this is how the cycle repeats. Cardiovascular diseases, obesity, and metabolic syndrome along with osteoporosis. So if I just sum up, the malnutrition in pregnancy leads to stunted growth, poor cognitive development, poor immune system, short height, cardiovascular disease, metabolic syndrome, osteoporosis, depression and schizophrenia and cancers. ये तो वो है जो हमें पता चल गए हैं। Maybe this is just a tip of iceberg. We might be having more than that. और आप जब रिसर्च करें तो हम इससे ज़्यादा बता सकते हैं। So what is the solution? Solution is balanced diet, giving the balanced amount of macro and micronutrients, energy, protein, minerals, fatty acids, folic acid and vitamins. कितनी अच्छी है डाइट लग रही है, looks so good. Energy requirement in pregnancy changes, और last trimester में it is almost 500 calories more than what is the basic requirement. अभी हमें तो पता है what to do, how to solve the problem of our women. So you need to do counseling, और counseling किसकी करनी है? कपल की करें ना? So you need to consult the women husband और मैंने आपकी आवाज सुन ली थी. So you need to consider the family. मदर को भी बताना यार इसको खाने पीने दो. And again story does not finish here. We need to conserve community. We need to sensitize our community about the changing needs of nutrition in pregnancy. So community should be sensitized that pregnant ladies nutritional requirements are for the generations to come. So she should be given the balanced diet, and it's our moral obligation as the clinicians to counsel everybody that what type of diet is needed for our healthy generations. So here the intergenerational cycle, यहाँ से इसको follow करेंगे. Malnourished adults, low birth weight baby, high mortality जो हमारी है perinatal mortality, impaired mental development, stunted child, reduced mental capacity, stunted adolescent, reduced mental capacity, and pregnancy of the stunted adolescent, low weight gain, higher maternal mortality. So this is how the cycle repeats and repeats. And here I am going to finish with a summary that pregnancy, health in pregnancy is hope. So we are hopeful for a healthy generation. Well-nourished mother, well-nourished newborn, well-nourished baby, and healthy adult. Stunted, malnourished adolescent, malnourished mother, undernourished fetus, low birth weight baby, malnourished infant, stunted child, and malnourished adult. So the generations are suffering. One mother affects with many generations, and your take-home message of today is healthy mothers make healthy nation. So eat right, stay healthy, and thank you so much.
Thank you very much, madam, for highlighting very clearly how the nutrition is important not only during the pregnancy but before the pregnancy, and how intergeneration cycle of malnutrition either related to obesity or undernutrition runs in a generation, and what we should do to break that cycle. Now coming to the obesity, which is a multifactorial issue and is associated with number of long-term conditions which puts the patient in risk of poor physical and mental health. And the management of obesity requires a holistic approach. We are honored to have with us renowned surgeon, a fellow in advanced laparoscopic and bariatric surgery, currently the principal and chief executive of SIMS Lahore, Professor Dr. Farooq Afzal. Please kindly, sir, elaborate for us on bariatric surgery and
they should be very beneficial. And how many should go holistic? What is holistic? Alright, so start with the holistic. आपने कार देखी कार, right? It has wheels, it has engine, right? So bariatric surgery का जो engine है वो surgeon है, right? But there are wheels around. गाड़ी का wheel उतार दिया जाए, would the car run? No. So all healthcare is actually like a system, and every service, especially the bariatric surgery, is like a system. And I give you the reason for that. Look at this man. ये आपके ख्याल में कितना kg होगा? Yeah, he's 500 pounds. So average weight of you probably would be 50 or 55 kgs. So what do you anticipate? What are the problems in this patient? What do you anticipate? Right, so starting from the head, you will see the anesthesia would be very difficult in this patient. Right? So monitoring anesthesia. इसी ने इसको लाया था यहाँ पे. So how ये 300 kg के बंदे को 250 kg के बंदे को उठाने के लिए कितने बंदे चाहिए यहाँ पे? Right? And look at the BP cuff. The BP cuff is here. So we think, we attend a workshop and we come here and we start bariatric surgery, and the end result is that we are not geared up for that. Because we think that if I know how to operate, that's enough. But that's not enough. So you need to understand that holistic concept, because everybody is essential when you are basically doing a bariatric surgery. So these are the few key questions I want you to basically know. The number one is obesity our problem? Yes. Right? And the second is, what is bariatric surgery? I will come back to you. Holistic service, why a holistic service is needed, right? And what are the components of that service and what are the hurdles? So the first question is obesity our problem? Yes. It's a global problem, right? 1/3 of US population is either overweight or obese. 60% of the world population would be obese or overweight by 2035, right? So it's a huge global problem. So when I presented for the first time, it's back in 2008, one of the professors, he came and he just stood up and he said, "Doctor साहब, आप अमेरिका से आ गए हैं, क्या बात कर रहे हैं? यहाँ पे तो हमारे सारे बंदों को तो रोटी नहीं मिलती और देखें कितने वार्ड्स में देखें जाके malnourishment, yes." So we have the double burden of disease, but we don't go and look for the literature. So this is a study, right, done in Pakistan by CDC and Harvard Medical College. Look at the prevalence of obesity in India. So it's a comparison between US and Pakistani population, and look at that, right? So this population, Pakistani population, especially age of 25 to 65, has similar prevalence of obesity, right? And this is back 1990. This is the current, right? Dr. Zulfikar Bhutta, there was a study published in Lancet about 188 countries. We are ranked 9th in the world as far as the obesity is concerned. And subcontinent is basically the capital of diabetes. The obesity-related diabetes is rampant, and this because the characteristics of Asian population is totally different. For the same BMI, let's suppose if I have a BMI of 30, for the same BMI, a Caucasian will have a less fat, and we have double the amount of fat. And the risk of metabolic syndrome and heart attack and other things are much higher. So this means this is our problem, and we need to address that problem. So what are the traditional ways we do treatment of overweight or obesity? So diet, exercise, medicine. Nowadays we have a lot of medicines. But we know that surgery is the only form of long-term and sustained weight loss. Still, we do not have anything related to that, right? So there was an NIH consensus panel conference in 1991. Till that, we know that, and that's what based on a huge data, Swedish obese subject studies, right? That was open surgery. Now, in 2022, 95% or more are done laparoscopically. So if you recapitulate the same data back in 1991, I think that we would have been much better to predict that surgery is the best form and the long-term sustainable. Obviously it has issues, but we will come back to that. So now coming back to what is bariatrics. So baro means weight, right? So weight loss surgery. So baro weight, so weight loss surgery. There is another term called metabolic surgery. Anybody knows what is that?
Yes, sir.
G.
Basically, when we do bariatric surgery in some patients, for example, diabetic patient, then it also have metabolic effects and it reduces the course of the disease. And,
Excellent. So when we do, excellent, thank you very much. When we were doing this bariatric surgery for weight loss, we saw that diabetic patients were also getting better. So now we use the intent. So if you use the intent for a metabolic correction, that surgery is called metabolic surgery. And if your intention is weight loss, that is called bariatric surgery. Alright? So there are two concerns about the bariatric surgery. One is that it's not safe. We know it's effective. The concern is not safe and it's very costly. Yes. So let's address these two concerns. So this is a lab's data, right, about the safety assessment. When I was a fellow in US, we were used to fill out forms for this longitudinal assessment for bariatric surgery, right? And this data, see, if you see the hernia patients, right, and the cholecystectomy patients, they have a higher mortality as compared to the bariatric surgery, right? And secondly, about the cost. So this is a Canadian data. So if you have spent $25,000, हमारे यहाँ पे 25,000 you can get it less than 5,000 US dollars. But for that bariatric surgery, $25,000. So within 30 months, that is taken care of. Because patient को जो उसकी बचत है in form of resolution of comorbidities and other stuff. So it is, initially it looks bigger figure, but it is compensated in the long term. Now, why we need a holistic service? मैंने आपको कार की मिसाल दी, गाड़ी की मिसाल दी. The reason is that obese alone, weight alone does not have an issue, maybe a mechanical one on backache and joint issues. But there are more problems with the with the comorbidities, right? So 80 to 90% of the diabetics are basically obese. So that's the issue. So we say that diabetes is the mother of all diseases. And we have a very competent endocrinologist sitting here. She knows better. Right? We have metabolic syndrome in Pakistan. 40 to 50% of our population is having metabolic syndrome. Right? And the consequences like hypertension, polycystic ovaries, right? Infertility, and cancers. So obesity alone is not a problem. It is the associated things that are the problem. And that's the reason we need everyone. We need a nutritionist. We need a physical therapist, we need an internal medicine boy, we need a gastroenterologist, we need an endocrinologist. No, so many people are needed for one problem, which is obesity. Now, my topic was to provide a holistic service. So what are the components of that holistic service? So there are some guidelines available. In US, there is a center, they designate something as a center of excellence for bariatric surgery based on these criteria. These are the 8 standards. आपके लिए बस just याद रखें. These are the 8 standards. And when I was there, we had, I think, 12 centers in US, center of excellence. One of our center was basically center. Now there are 848 center of excellence in US, right? And we are still trying to develop center of excellence in Pakistan. There are many hurdles, I'll come back to them. So what do we need for that? There are 5 things you need for a center or setup. You need people, you need facilities, you need equipment, especially the equipment, and there's a process, and then lastly, the procedures, right? So what are the peoples? All these people, surgeons, trained anesthetists, all these people are needed, right? Now, surgeons, minimum volume of 25 cases per year. If somebody is not doing 25 cases or more, he should not be doing bariatric surgery, right? Now, what about the theaters, facilities? We need a dedicated theater. It cannot be started in a clinic. We have to have an ICU and other facilities. Radiology scanners should be also big, right? So these are the things which we need. Now look at this table. You have to have a split leg table. Our standard tables can hardly bear 150 kg. So they cannot be used. Their dimensions are also very small. These tables can take 1,000 pounds and they have the ability to basically have a split leg position. Normally you will hardly see the split leg. ये lithotomy position नहीं है, right? Split leg is split, right? So this position, and when you are basically doing it reverse Trendelenburg, the weight on the foot pedal is almost more than 1,000 pounds, right? And this patient can fall during surgery if you are not particular about that. Now, instruments. Okay, look at the anesthetist. He has to put many towels under to make a snitting position so that he can put an endotreatment. So not everybody can, every anesthetist is capable of managing such patients. No, we need longer length instruments. Laparoscopy started in 1991 in Pakistan, and at that time I remember I was training. Obesity was a contraindication for laparoscopy, right? Because we were not having that longer instruments and stuff like that. Now look at that. Normally we use 33 centimeter long for a lap Foley. If I am operating on one of you, probably I would just need 33 centimeter. But here we need up to 45 centimeter. So look at the impact of fulcrum. We say that 1/3 should be out and 2/3 in, right? Instrument. So look at the effect on the surgeon's hand. So most of the times I am suffering also from the neck problem and stuff like that. Most of the surgeons suffer from ergonomic issues because of their fulcrum effect and the positions. The process is same. There is a pre-operative phase, there is an intraoperative phase, and there is a post-operative phase. And what is the purpose of pre-operative phase? Basically, you screening. A lot of them will have diabetes, hypertension, psychosis, right? They need consultation, nutritionist consultation. So that is done. The second thing, you basically identify the risk assessment. Now, MBS DEPA, a comprehensive center can only operate with patient who has end organ damage, right? And low acuity center cannot operate on that, right? So screening is very important and risk assessment is very important. So pre-operative preparation of the patient and risk assessment is the fundamental part of any bariatric surgery program. Secondly, intraoperative, you have to have a standardized approach and plenty of equipment, especially in Pakistan. So once I was operating and we had to use extra 2 cartridges and they were not available. And we were stuck in the middle of the case because the pharmacy has no cartridges. So we had to wait for 25 minutes to that cartridge to be bring up from outside. Right? And whenever you are in problem intraoperatively, you must ask for help. Second is post-operative. What is the purpose of post-operative management? Pain management, identification of risk of early complication, and then follow. So this is the process we adopt. And these are the fundamentally 3 procedures. Right? आपने से किसी ने sleep gastrectomy तो देखी होगी? Right? So sleep gastrectomy. So the purpose of sleep gastrectomy is that most of your ghrelin hormone is produced in the stomach, 60 to 70%. So if you remove this portion of the stomach, you remove the ghrelin hormone that reduces your appetite, because ghrelin is what? It's a hunger hormone, right? That reduces your appetite. So this is a moderate weight loss. It can reduce your weight from 2 years up to 60% of your excess weight. The other is gastric bypass. This is still the gold standard. And the third one is the mini gastric bypass. The mini gastric bypass is purely a malabsorptive procedure. There is some reduction in the stomach, but purely malabsorption. So अब क्या होना शुरू हो गया? Our surgeons go outside from India and they learn this procedure without knowing the long-term problems. The long-term problem in our population is malnourishment. People only come when they have developed severe deficiency, right? And that's not treatable. I've seen one lady dying 2 years after the mini gastric bypass. Secondly, I still am not convinced this mini gastric bypass, there is a reflux of bile into the esophagus. And this small tube is not that enough. But still, the Roux-en-Y gastric bypass is the current gold standard. There are other procedures which you need to not to know. Now, what are the hurdles? Why we don't see here in the public sector? The cost, right? I'm General Secretary of the Pakistan Society for Metabolic and Bariatric Surgery. We established the society in 2018 and we had only 12 members. Now we have about 70 members, right, over a period of like 5 years. And I think in Pakistan we have at least 7 big centers operating. So that includes the Services Institute of Medical Sciences.
There was a program run by
Okay, so the hurdle is cost because one surgery costs about 300,000 US dollars, 300,000 Pakistani rupees. That's very cheap, right? But it's our governments cannot afford that, right? जब हम बात करते हैं कि इस पे वो कहते हैं कि हमारे लिए एंटीबायोटिक्स और पैरासिटामोल बहुत इम्पोर्टेंट है, ये गैजेट्स हमारे लिए इम्पोर्टेंट नहीं है, ठीक है? So but we are struggling, inshallah, it will come up. In the private sector, again, this is the cost. Right? So nobody wants to invest, they just want to have a business. Okay, so I leave this summary to you to conclude. Right? So obesity is our problem. That's fundamental. You need to know that. And surgery is the best long-term method of sustained weight loss. And we need multiple specialties to develop a holistic service. And secondly, a standardized approach to quality improvement like MSD, like we should need to develop such registries. Thank you very much.
Of obesity and the need for holistic approach for this, and your message that there is quite vacancies in surgery and the new generation should adopt surgery as their specialty. Now moving on, I would like to introduce one of the most esteemed guest speakers present here. He is Dean, Faculty of Gastroenterology, College of Physician and Surgeon, Pakistan, President, Society of Gastroenterology. He is Professor of Medicine, Consultant Gastroenterology, having vast experience in interventional endoscopy. I invite Professor Ryasul Nabi Tayyab to discuss about the recent endoscopic intervention. Please, sir.
My class fellow as well, and Dr. Shamsama, you are a long-standing friend, and the management of FJMU for inviting me here to talk on the subject, endoscopic intervention of holistic services, just in the same line as Dr. Farooq has given an overview about bariatric surgery, although he has touched on a very focused on bariatrics, although I was of the impression that holistic means that possibly Farooq is going to talk on the psychiatric aspects of obesity, nutritional aspects of obesity, medical management of obesity, and then one of the components, surgical method. Just to stimulate the people, encourage the people to come into a field like bariatrics and then surgery, he has focused more on the bariatrics and bariatric surgery alone. So my job is to give you an overview about endoscopy, how to develop a holistic approach, and what has been my experience until now. And but before I go into that, let me invite all of you in the upcoming annual Congress of our Society of Gastroenterology, which is going to happen on the 22nd to 26th of February in Pearl Continent Hotel, and it's going to be held under the offices of our Society of Gastroenterology. It's open for medical students, it will be very useful, beneficial for students of final year, and you want to welcome. There are going to be interesting sessions on the basic execution approach. I don't have any disclosure on that. And the next slide is Future 2070. Can anybody guess who was the person who wrote this Future 2070? And writes, the future belongs to those who can imagine it, design it, and execute it. It's not something you wait for, but rather create. So you are the people who are in the right capacity, you are the people who are in the right age where you can create. So anybody who guesses who was the author of this statement, I'm going to give him a special gift. Anybody? I've given a hint, Future 2070. ये हमारे लीडर्स नहीं है जो कि अपनी कौम को खाते हैं, irrespective of the political party. That this is future 2070, the second most populous city, the ruler of the second most populous city of the world. And then another saying, we may not live for the hundreds of years, but the products of our creativity leave a legacy long after we are gone. The presentation given by Professor Khalid Afzal, presentation given by Professor Shamsa Mai and Dr. Vedato, the legacy should continue. Even if we have left, still things should go on. And let me tell you, this was the first institution when I joined as when I got promoted as faculty as way back in 1993, and I joined this institution as assistant professor, and this was the lecture theatre where I gave the first lecture. I think it was 30 or 40. Now, when we talk to the holistic services, this is what we are talking about: a triangle of demand versus supply, financial support, admin support, political employment, motivation from the community, motivation from the peers, motivation from the seniors, and then based on that, we are able to develop a holistic service which involves a satiety. कुछ नहीं करना, मुझसे नहीं होता, बहुत मैंने कर दिया काम, लोगों को नहीं पसंद, लोग नहीं करने देते, यहाँ पे कुछ नहीं हो सकता, पाकिस्तान है ही गंदा मुल्क. But then there can be hunger for knowledge, empowerment, ability to do something, and then layer of getting, हाँ जी मैंने कुछ किया है, मैंने कुछ करके दिखाया है, मैंने बना के दिखाया है, and then deciding that what exactly is the need for the community. What should I design? How should I design? How should I implement? And present it at different forms to get funding, to get what is there in the mind of the person. So when you have a supply and demand, obviously demand depends on the number of patients, number of people in the society requiring a particular discipline. I still remember way back when I was a student in the college, and cardiology was coming up at that time. And I used to hear from my senior professor in K, it used to be the case that the senior professors, they used to be the professors of medicine, surgery, gynecology, and blah, blah, blah. But then at that time, my senior professors of medicine used to say, cardiology का की काम है, ऐसी जिन्नी cardiology ना करनी ऐसी भी कर सकते हैं. Look at the cardiology at this moment, and look at the medicine now. Now medicine is definitely a base camp, and from medicine, obviously the new specialties are going to generate. So depending upon that, obviously increasing burden, the number of patients in the society, the complications that we get. You have heard Professor Farooq Afzal, basically, who is the, by the way, boss of the body? Can anybody say that? वैसे किसी ने नाम दिया नहीं मुझसे. पिछला जो मैंने कहा था फ्यूचर 2070 किसने लिखा था? चलो ये है चांस. हाँ?
Sir, Sheikh Mohammed bin Rashid.
Very good. You get the prize from me. 96. When I went to Dubai for the first time, like, hey, छोटा है Dubai का. I was able to walk through Dubai in one night because it was just a transit for me. And let me tell you, now Dubai is the second most popular and most touristic city in the world. So just see, just look at the vision of that person, and Vision 2070 is the one on which they are working. So coming back to the topic. Complication. Who is the boss of the body? Second chance to win for the girls. Who is the boss of the body? Heart. Like bachchan nahi. Nine. Boss of the body is liver and liver. 9% of your diseases start from the liver. Metabolic disturbance in the liver leads to diabetes. Metabolic disturbance in the liver leads to heart diseases. Metabolic disturbances lead to hypertension and all the other ailments. So most of the body is liver. And the number of patients suffering from liver disorder is to the tune of roughly about 15%. Hepatitis C, hepatitis B, and obesity related non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, these are the one. And then the इंटरनेशनल पीयर प्रेशर, डॉक्टर इतना बाहर से आई हैं एंडोक्रिनोलॉजिस्ट, क्या मुसीबत है, अपने फैमिली के साथ आई हैं, छुट्टी गुजार रहे हैं, फैमिली के साथ एंजॉय कर रहे हैं, and she's here to tell you about new aspects of malnutrition, new aspects of nutrition. This is called international peer pressure. And on the supply side, there's the return migration. I came back from UK, my colleagues like Professor Markhan came back from USA, and so many others who returned from abroad to serve the own nation, and then local skill development and local workshops. And then obviously the progress is made based on people getting trained, people are getting treated, people are trying to perform advanced procedures, and then certification, focused knowledge. Previously, FCPS in gastroenterology was not there, so now FCPS in gastroenterology is there. Previously, advanced certification programs was not there, now we bring in advanced certification programs in the advanced endoscopy services, neurogastroenterology services, and transplant technology. So whenever we have to develop holistic service, obviously we need to have an infrastructure, the kind of infrastructure that Professor Farooq mentioned in his theatre environment. Then trainers and trainings, unless the trainers are there, unless the trainings are available, holistic service cannot be developed. And then training paradigms. Somebody has to sit down to write down what should be the curriculum, what should be the syllabus, how should a person be monitored, and what should be the parameters before we certify that this person is good enough to work in a particular specialty, and then guidance position papers given by Pakistan Society of Gastroenterology or the relevant society. So starting with endoscopy, way back when even I was not born, the people used to do endoscopy as it is on the left-hand side of the garden, and then a telescope was introduced, and on the bedside, while the people used to be screaming, and I've seen the people that are doing endoscopy like these in my younger days. And then came this particular time when in 1982, the first endoscopy was done in the country in the hospital. And this is the third modern endoscopy suite, which is more like a mini theatre. So we have traveled long from this to this. And right now, the endoscopy is pretty advanced, starting from a basic fiber optic endoscope where we used to look down like this, and for hours and hours, we used to keep one of our eyes closed and look down in the eyepiece and down into the stomach. And remember, those of us who have grown that, if you look at us carefully, हमारी एक आँख छोटी नजर आएगी आपको, for the reason being that for long hours we have been keeping one of our eyes closed to look through the lens. And then came the video endoscope, and this is the important endoscope, and this is where the future lies. Aortic endoscopic surgery is coming up. We are fast taking up the place of surgeons, even in the bariatrics. We are going into the balloons, we are going into the endoscopic gastropexy, and maybe soon Farooq Afsar may find very difficult to continue with this bariatric surgery to the tune that he's doing. I'm telling Farooq. So, what exactly do we need? We need space, we need equipment, we need reporting system, we need records, and we need disinfection system. And when we talk about the trainees, obviously trainers have to be qualified, they have to be trained, very accomplished, experienced, and then they need to have a training attitude as well. बहुत अच्छा कोई आ जाए, दुनिया का बेहतरीन परफॉर्मर आ जाए, but if he doesn't have the attitude to train the younger one, or have the patience to train the younger one, उनकी सब जो बेवकूफ़ियाँ उनकी हमारे उनको टॉलरेट करने उसमें मत ना हो, he is no good as a trainer. He may be a very good and experienced person, but not a good trainer. And then from the training side, to ask only in the future, you need to be willing, you need to be dedicated, hardworking, and you need to have an intellect to learn the new things, especially the higher procedures. And when it comes to the training opportunities, one can have formal training opportunities like certification programs, horticulture programs. Then one can learn through the hands-on workshop, hotels, and observational skills. And informal, you're working in a department where procedure is performed, where discipline is being followed, and just by experience you're learning things. And then compulsive learning कि आप एक supervisor क्या हो, बंदे का मसीह सीखो, सीखते हो कि नहीं? आज ये तीसरे सीट की जाती. So that's what's called compulsory. And then when you look at the learning opportunities, we need to have guidelines and position papers. And remember one thing, I tell my students and I tell my junior doctors, कि यार मेरी personal medicine कोई नहीं है. Don't try to quote me at any stage. If you think that X, Y, Z has said this and I'm going to buy that, the answer is incorrect. Guidelines are there for each and everything, irrespective of whether it's diabetes mellitus, it's an acid-hepatic disease, or it's a bariatric surgery, management of obesity. Guidelines addressing the minutest details of a disease are there to be followed. Just follow the guidelines, and whenever you ask and whenever you challenge that why have you done this, just give a reference that I did this in reference to the guideline given on that paper. So in my domain, we have American College of Gastroenterology, American Gastroenterology Association, American Society of Gastroenterology, British Society of Gastroenterology, Asia Pacific Society, diseases, and Asian endoscopic ultrasound. And then on the local side, we have Pakistan Society of Gastroenterology. Now, my personal experience in developing holistic services in Punjab, and this started way back in 2017 when I was given a charge of project director to develop endoscopy suite, GI unit, and the products attached to each medical college in Punjab. So at that time we had 17 medical colleges, and my mandate was to develop one gastroenterology unit, one endoscopy suite, and nurse clinic, and that had to be completed in 3 ways. The budget was 5.5 billion rupees that was given to me, and in that we had an infrastructure of, as per pre-existing criteria, these 3 things: one OPD clinic, inpatient 40-bedded unit, and then endoscopy suite as per the standards given by American College of Gastroenterology and PMBC. In the equipment, the basic equipment which is needed for 90% of patients, upper GI endoscope, lower GI endoscope, duodenoscope, I know these words they will bring to you, but as a comprehensive approach, all these equipments were arranged for these people and human resources. Newly trained people or people available in the community who had done FCPS in gastroenterology, and the number of people who had come back from UK and USA who had done their fellowship or they have completed their gastroenterology training, they had returned to Pakistan. They were recruited as trainers, faculty slots were created, trainees were there in the community, nurses, technicians, support staff, they are mandatory to develop any service, to bring any service. So in the project we had 3 things I've already mentioned, and administrative control had to remain with the principal and medical supervisor. So these teaching units were supposed to supply human resource for Punjab Kidney Health Institute. I don't know how many of you about this problem. To all the reference clinics, to all the GI units, and in the private sector as well as in the public sector. So what had to be the impact? The impact was that we had to treat 3,70,000 patients per annum, which we achieved in 2019-2020, but then with the change of government and mismatch in supply and demand, things fell down. 1,25,000 hectares C patient, estimated number of hectares E patient that we treated 13,600, but more important for you, the number of beds added to the system 680, which is a big number in the public sector. Estimated number of endoscopic procedures per annum 66,000, and total number of posts 1373 had to be added, and out of them 87 PD trains, meaning that 87 gastroenterologists are expected to be added every year in the pool of gastroenterologists. And this is the working model, starting with, although we were not able to complete because of the change of government, but this was the holistic model that starting with these, they had to report to the professor had to report to principal, principal had to report to the steering committee and Punjab Institute of Digestive Diseases, and then we were supposed to report to the specialist healthcare department, and that was in total holistic approach to develop GI units in various hospitals and GI services for the public at large. Once again, reminder that we have a conference coming in February 2023. I thank you for your attention.
a renowned child specialist, belonged to Harvard Medical University, dear friend, visiting from USA and present in the audience. Dr. Khalid Miller join करना है. We also welcome Professor Naveed Hodiana. We welcome the most beloved faculty members and our special guests. Assalamu alaikum. So now we move to the second topic of this seminar. We will have two lectures related to hearing and hearing disorders. So I request one of the top reviewed ENT specialists, Dr. Afzal Ali, the best consultant audiological physician, to brief about neonatal hearing screening.
Respected faculty and my dear students, I'm grateful to the organizer of the symposium, particularly from FJ, BC Team and Capcana UK, those who have provided me an opportunity to talk about the subject which is important, sensitive, but it is quite ignored. And the subject is the speech and language development of hearing impaired children. And the title is Verbal Mode of Teaching to Hearing Impaired Children. Before going to the more details, let's have an overview of the special education in Pakistan. Pakistan is, one of the most populous countries in the world, but on the literacy rate, we are on 1/60th of number. And we spend just like 2.5% of our annual GNP, that is the gross national product, on education and training. Whereas the population is like 2.49%, which is disabled. The first school in this respect was started in 1906, but it was mainly to cater the people with visual impairment. And then in 1920, another school was opened in Karachi. It was for the deaf children. The things were continued in early 50s. There was a society for deaf and dumb community, and they thought about something about the educational services, and a school was started in Gulberg, Lahore, with the name of Gomel Palace. That school still exists there, but it is with the Punjab government. Magnitude of the hearing problem. According to the World Health Organization, 5% of the population is having hearing impairment of different severity. In Pakistan, the total population, we know it is more than 200 million. So the hearing impaired population is around 10 million. So, my dear, it is 1 crore के करीब जो लोग हैं वो hearing impaired हैं पाकिस्तान. So just imagine the size. And so large number, but availability of resources is very limited, and the opportunities are very limited to this segment of the population. Number इतना बड़ा है, resources बहुत कम है. That is the obvious reason for depression, oppression, and lack of opportunities. The Pakistan Society of Audiology and Speech in 2022, they told that 3% of Pakistani children are born with hearing impairment. So again, it's not a small number. The number goes around 1 million. 10 lakh के करीब बच्चा जो है of different severity as hearing impairment. But you see, the 10 lakh तो है, but how many of them are enrolled in proper educational institutions? So it's just the 46 institutions in Punjab, which is half of the Pakistan, and it's more than half the population of the countries in Punjab. And only 21,332 children are attending the school. So, 10 लाख में से 21,000, अगर पंजाब की बात करें 5 लाख में 21,000 are going to school. Keeping in view the stats and my personal experience in this field since 1994, I found a huge gap between the size of the population who needs the rehabilitative services and the available opportunities of these services. So I myself thought this idea with some of my friends and family members, and we developed an NGO, an organization with the name of SADA, Society for Audiological Developmental Areas. The society was developed in 2014 and it was registered with Department of Social Welfare Punjab, but currently it is registered with all the relevant regulatory bodies in Pakistan. What was the main mission? Mission was actually to enhance the intellectual abilities of the hearing impaired kids to prepare them for the mainstream education. And what are the goals of this organization? You see 3 points. One is that you give them the hearing. Second, you teach them the speech. And third, create awareness and give them a proper educational services. So, to give them hearing, we organize hearing aids, cochlear implant, either free or at a highly subsidized rates. We free highly subsidized structured school program. We give speech therapy sessions throughout the province of Punjab, and we do a lot of things for the awareness. So, we have, like in Punjab, the 8 different regions in Punjab where we are providing the speech and language therapy services with the help of the local speech therapist. So the model is such that the people who are living in the far-flung areas, they should not come to Lahore and the bigger cities to get these services. So we have deputed or we have collaborated with the speech and language therapists in those regions to provide the services for the deserving community. Awareness. Of course, as it was in the goals, that awareness is a very, very important issue. You know, the hearing impairment or the deafness, it is generally an ignored disability, unnoticed disability. Because if somebody is polio affected, you can see. If somebody has the visual impairment, you can very easily say that he is blind. But with the hearing problem, the parents, they bring the child to the audiology or to the ENT departments at a time when the most important or the crucial part is gone. That is the speech and developmental age. So, the SADA does a lot of things for the awareness. We are present on the social media. We do a lot of on the electronic media. And then we regularly develop the medical camps. 3rd March of every year we celebrate International Hearing Day, which is declared by WHO, and our gatherings are huge. A lot of people come in those seminars, and we penetrate to the society more and more to sensitize them, to educate them that how important this issue is. Partners. You see, no organization can work all alone. You need to have support of the whole society. So similarly, SADA is collaborating with the different partners. And the core reason for this partnership is, one is awareness and other is to improve the delivery services. So in 2015, we achieved 1 key milestones for the hearing impaired children to promote a language and a verbal mode of communication. We formed a school with the name of Alam School for Speech and Learning. It was founded in 2015, and we have a reasonable, decent number of staff. We have like 6 teachers, 3 speech language therapists, we have psychologists, we have dietitian, we have audiologists. So all the services which are required for a hearing impaired child is available at one point. When the school was started in 2015, we got only 2 students. But now, alhamdulillah, we have 26 students enrolled. We keep that child for 3 years with us, and then he is sent to mainstream education for the normal language development and to become a normal citizen of the society. So we have, alhamdulillah, sent like 34 so far. Children are studying in different normal schools, and we have a strong alumni which is being developed. And the Sada has a very strict belief in this thing, that we have a very strong connection with our alumni. If they have any problem, they can come back to Sada to take any help of whatever of the kind. Services and facilities. Our School for Speech and Learning, providing the audiology, speech services, hearing aid, accessories, highly subsidized cochlear implant. Ladies and gentlemen, I tell you one thing. These amplification devices are not cheap. They are very, very expensive. For example, one hearing aid costs us around 20,000 rupees. And the cochlear implant, which is a revolutionary treatment for the hearing impaired children, it is around, the cochlear implant, the cost is around 2 million rupees. So now I will show you a video clip of few seconds, which will be telling you that how a hearing impaired child is trained to hear, to form the words and then develop the speech. Shall I will? So this is auditory training. He is hearing sounds of different frequencies and he is responding. He may be like 2 or 3 years of child. So this is, for example, 3 years of child, and after a few years, what is the speech development sample?
क्या हाल है आपका? Okay. What is your name?
Profoundly hearing impaired child with cochlear implant.
Ibrahim bin Sandeepa.
Okay. How old are you?
I hold 6 years.
I hold 6 years.
Tell me आपके स्कूल का क्या नाम?
The Hawk Grammar School.
अब आप कौन सी क्लास में हैं?
1E.
Okay.
My big class.
Okay, you are in a big class. इब्राहिम मुझे बताओ, अभी जो स्पोर्ट्स डे हुआ था, उसमें आपने क्या खेला था?
Circles, skipping rope, first.
ठीक है. आपने बात की मुझे.
Okay.
सब की आप खेल चला है.
So you see, I mean, he is a boy who was profoundly hearing impaired. When I say profoundly hearing impaired, साथी जुबान से कहते हैं जी completely deaf. So you see, now he is studying with the cochlear implantation, speech language therapy in a normal school, mashallah, with a normal language and speech, and hardly one can imagine that this child is not hearing. Hardly. Neonatal hearing screening. It is, you see, very, as I told you in the previous slides, that early identification is very, very important. It's a key issue. If there is early identification, then early intervention, and we can raise the child as per our objectives and goals. We have developed this neonatal hearing screening program for last 2 or 3 years. And how many Amna we have done so far? Almost 300, and we are collaborating with Sheikh Zayed Hospital, We are collaborating with Services Hospital and Gangaram Hospital with the support of Naveed Hotiana Sahab. So, Vice Chancellor Khalid Masood Gondal is always patronizing all such good and creative activities. So neonatal hearing screening is done according to the international guidelines. According to the international guidelines. So our objective is not only to keep the child in an educational school. In order to empower the child, in order to develop a level of confidence, we do a lot of activities outside the school. We organize the different activities outside the school. We send the children to participate in the areas of national importance. So in this way, we develop a kind of confidence. Next, beta chalana video clip is a very small video clip which I'll show you that how we send the kids to enjoy and to develop more confidence in different. These are all children from our school. Such activities. Next. So you see, the importance is that you do not only teach them a curriculum only in the routine work. No, they should be in some other environments to gain more confidence. So. Upcoming projects, we want to have a mobile unit in order to extend the neonatal hearing screening services to all the areas of Punjab. We have the plans of developing a purpose-built campus for the Alam School for Speech and Learning. My dear students, I tell you one thing, that we have a lot of pressure for the different hearing impaired families for the enrollment in our school. But we have a very limited space. We have very limited resources. So, but we are aiming to build a purpose-built building, inshallah, near future. And extension of the preschool to the grade 10. Now, at the end, we have a signature song for the children enrolled with our school. So just a few seconds. So I hope it will be good for you to hear that song and you will enjoy the activity all these very different children. See their facial expressions and their movements and acts. It's not a blank look, it's a confident look. When you go home, take this message of Sada that all the segments of the society has to support such activities in all areas. Thank you.
Really appreciate and acknowledge your contribution to the humanity and how you are bringing life normal to them. People and the children live normal, happy, healthy life. Thank you very much. We appreciate your services, sir. Teaching deaf children to improve the quality of their life is a challenging task in itself. Family Educational Services Foundation is a non-profit organization that is operating in Pakistan for the last 3 decades. Dr. Daniel is the co-founder and director of this organization. He is the driving force of the Deaf Research Program, a unique academic and skill training program for the deaf that utilizes innovative technology-based resources for the educational and the skill improvement. We welcome Dr. Daniel to highlight about this teaching program.
So while we're setting up, I would like to thank Mr. Afzal, who has given a presentation about cochlear implants. So we are going to do the opposite.
So we did not turn off the sound.
Ali?
So we will teach you your first sign. You don't clap. This is how you clap. See, I knew you were all handicapped. My name is Daniel Mark. In sign language, this is how you spell my name. D-A-N-I-E-L. But that's very difficult. I knew you were handicapped. So sign language is actually very efficient language. A number of studies, books, experiments have been conducted. And in sign language, my name sign is D. Dil Daniel. I would like to introduce you to my colleague.
Assalamualaikum. My name is Saba, S-A-B-A, and my face sign is S because of my hair, so Saba.
So Saba is the coordinator of the activities of the Deaf Reach Lahore, which opened in July 2020. She's been with us since January of this year. But Saba, you also have another title, I believe.
Yes, I am a coda. CODA is an acronym that means Child of Deaf Adults. मेरे parents deaf हैं.
What do you mean, your parents are deaf?
Yes.
How did you learn to speak?
Speaking is my second language.
What was your first language? So you got it. It's sign language. So we're going to talk about this. This is what Deaf Reach, its strength and core program, is to teach sign language to the deaf community and also to the hearing world. And also you are
I am a graduate. I have done my master's from UHC in counseling psychology.
So we would like to thank Dr. Atar Sahid for inviting us today, and for the alumni. There's a problem with the light. No, just this. Where's this fan? Oh, it's a fan. Can I do anything about that? So we believe that deaf can do anything except. Is this possible?
Yes.
Here's an example. And over the years, we have done some linkage with different organizations. And one of them is the American School for the Deaf, which is based in Connecticut. And they have accepted 2 of our students on a 5-year free of cost residential scholarship. Our students have graduated and now they are going to college, hopefully to university, and then we bring them back to Pakistan as deaf leaders. So, okay, so we just want to show you a segment of this 19-minute documentary that's available on YouTube and Deaf Reach YouTube channel about what is deafness. But we're just going to show you the first segment because it's applicable to set the stage for what I'm about to say next.
By deaf children and their families. We will discuss the causes, the types of history, as well as the history and education of the deaf. Instead of focusing on defect to be fixed, we will take a look at the unique deaf culture and the beauty.
It's playing 2 times. This is why it's called IT. Inshallah Ta'ala.
The goal of this video is to help you better understand what deafness is. The goal of this video is to help deaf children better understand. By deaf children and their families. We will discuss the causes and types of deafness, as well as the history and education of the deaf. Instead of focusing on deafness as a defect to be fixed, we will take a look at the unique deaf culture and the beauty of their natural language. which is sign language, and the important role that it plays in the education of deaf children. Having a mindset that being deaf is a deficiency, many well-meaning parents and doctors work hard to make their children undeaf, or so-called normal, forcing them to speak and lip read instead of sign. In the meanwhile, precious time is lost as many deaf children grow out of that crucial early language acquisition phase. Their lack of language and not of hearing then becomes their most severe disability.
Sorry, you mentioned about, so skip that. You can see it's available over there. But I think he's made his point in that instead of focusing on the deficiency, on deaf loss, we're going to look on deaf gain. So it's available on the YouTube. You can look at it. It's very, very good. It gives you all the information that you need about deafness in 19 minutes. We're talking about cochlear implant. It's a solution for some, but not for all. Cost is prohibitive. Services as such as Mr. Abdal and his institution, Sana is doing, it's very limited. And the parents need to have make an informed decision before implanting their children, because they think it's like glasses. You have bad eyesight, I go get a prescription, I get glasses. Oh. With deafness, get an implant. If you get it done post-lingual age, it doesn't give you speech. You have to go to speech therapy.
And some parents are getting free cochlear implant, but they don't realize the extreme cost of follow-up for speech therapy, calibration, maintenance. So yes, we do not negate cochlear implant. Actually, our school in Sakar is partnering with Dr. Rahim Bhatti at the Gambat Institute of Medical Sciences. 10 of our deaf students have been implanted as a pilot project. However, the condition was that they remain in deaf education because research has been done that many people who have been implanted post-lingual, even though they grew up afterwards in the hearing world, eventually as adults they identify more with the deaf community. And that's very clearly brought out in this beautiful video that you can see on YouTube that explain the struggle of this family, and later on as an adult the daughter decided to be more part of the deaf community. So some numbers, 70 million people globally have some hearing loss or deafness. 80% live in developing countries. Only 3% of programs include sign language. In Pakistan, they say there's 9 million people who have hearing loss. Somebody said including the government and pop. So, but then less than 5% have access to education. So we mentioned earlier the problem for deaf children is just not lack of education facilities, but language deprivation. We opened a school in Sakar. An 18-year-old and a 4-year-old are both in KG because they have no language. 90% of deaf children are born in hearing families. So if you're fortunate enough to live in a city, in an urban setting, in Pakistan, like Karachi, Lahore, Rawalpindi, maybe you will have access to some facilities. But 60-70% of the country lives in the rural areas. So if your child becomes deaf by birth or congenital, then what do you do as a parent? So your child grows up with no language. So you need a language is fundamental to communication, to education. It gives a voice, it gives empowerment. I should have asked anybody here that has any relatives who are deaf? 1, or friends, 2, 3, 4, 5, 6, oops, hands are coming up, right? So we're all somewhat touched friends, relatives, close, far, and it's affecting everybody. So we have a solution that is also for everyone, the hearing and the deaf. So a hearing child will have heard or integrated up to 15,000 words by the age of 5. A deaf child, if he's lucky enough, 50 to 100 words. And again, if you live in a rural setting, then you would have developed your own made sign, which are more like survival signs than actually a real language. So is sign language universal? Who said yes? Who said yes? Don't be afraid. There are no wrong answers in my class. Who said universal is, sign language is universal? Okay, now there are more brave people. Well, actually it's not. And the reason we think like that is because many of you were born or grew up with this. Right? So we think because of technology, it's also unifying our language. My mother tongue is French. I learned English because I live in Canada. We speak English here because the British were here. So to have a universal language, it takes a political power, it takes military power, and it takes many years. So this is why we speak English in some continent. But sign language is a grassroots language. It's an indigenous language of the deaf community in any of the countries where they are residing. For example, Canada, United States, British, New Zealand, Australia, they all speak English, but the sign language is different. Because sign language is not based on a spoken or written language. It's its own language. And it's not recognized by the United Nations as official languages. And this is why the 23rd of September is declared International Sign Languages Day. So out of nearly 300 sign languages in the world, Pakistan Sign Language, or for short PSL, and not to be confused with Pakistan Super League, takes pride to be one of the 138 languages that are documented. Isn't that nice? Yeah. And Deaf Reach did that. We like to take the boasting right of having documented the existing language. We built on what other had already done over the years. And then we documented the 2,500 existing signs that were common throughout the country. And we added an extra 3,500 new signs. And now we're adding an extra 1,000. So there'll be about a 7,000 visual dictionary available. And that's there. It's called PSL, Pakistan Sign Language. It's available on the internet. It's available as a phone app on Android and Apple. So there's a visual dictionary of 6,000 words, 500 videos for teachers to learn how to teach in a classroom setup, 100 stories for kids in sign language. Everybody loves a story, but who will tell a story to their kids when 90% of them live in hearing families? And then there's a computer game to learn to read, write, sign, and over 700 videos to teach basic reading, writing, math, science. And our goal is to be able help us to do the entire national curriculum for all subjects, for all grades in sign language. Because remember, the two big hindrances to education for the deaf is accessibility to the facility, and second, to have access to the education in their native language. If we all go to China tonight for dinner, we're all handicapped. And if you're going to stay in China forever, you never learn Chinese and then never learn Hindi, Urdu, Punjabi, Mayu, whatever language, then we're handicapped for the rest of life. So we want to make this available for everybody besides our schools. And here's a sample of the dictionary. Sorry, the sound is missing. School.
College. College.
University of Punjab. Punjab University.
And now we're going to teach you all a sign that's very important. Almost.
Lahore. Lahore.
L and the place. And I moved to Lahore 3 years ago, and I was told that Daniel, please get adjusted in Lahore because there are 5 seasons.
Wedding. Shak.
And what do you do at Shadi?
Bhangra. Bhangra.
Here's a trailer of the stories, and on the website you can have access to it in English or in Urdu through the voice over and with the script.
There was once a poor man who lived with his wife. They lived in an old house at the end of an old village and kept their animals in an old barn. Both the man and his wife were farmers. They also had a dog and a cat and an old cow who gave them milk every day.
एक दफा का जिक्र है कि एक गरीब आदमी अपनी बीवी के साथ रहता था। एक गांव के किनारे पर एक पुराने घर में रहता था। यहाँ उन्होंने जानवर पाले हुए थे। दोनों मियां बीवी किसान थे। उनके पास एक कुत्ता, एक बिल्ली और एक गाय थी, जो उन्हें हर रोज दूध देती थी।
The videos were made, the stories were made in Lahore, and the filmmaker, the actor, the interpreter was done in Karachi. So a lot of good things come out of Lahore. So, sorry, we would like now to give you a glimpse of what Deaf Reach is offering, and I would like to ask Sabah to do that.
So, Deaf Reach has 8 campuses across Pakistan, and Mr. Richard is the CEO. He started Deaf Reach program. He got the Sitara Khidmat Award last year by President Alvi.
So why did he start Deaf Reach?
Why he did start Deaf Reach? So Mr. Richard's son, Aaron, he became deaf through type 5, and that is how he started Deaf Reach, because that time he was in Pakistan and there was no sign language for his child to, so this was the initiative he took, and he started Deaf Reach. And we have now 8 campuses across Pakistan. So this is the motto and this is the aim of Deaf Reach. We educate leaders among the deaf and empower deaf to, for their job and employments. So what Deaf Reach has done and what Deaf Reach is doing, इस वीडियो में आपको complete package जो है वो मिलेगा। ये 5 minutes की वीडियो है।
The deaf should be viewed not simply as a disability group, but as a distinct cultural group that communicates in its native language, which is sign language. education is the key to empowerment for this marginalized and underserved community. Established more than 2 decades ago, Deaf Reach schools, training centers, and colleges provide free education and skills development for deaf children, offering them the opportunity of a transformational education and empowering them to achieve gainful employment and an improved quality of life. 7 Deaf Reach campuses located in Karachi, Hyderabad, Nawabshah, Sakkar, Tandwalayar, Lahore, and Jhelum comprise a national deaf school network serving both urban and rural areas. The college and Bachelor of Arts programs provide a pathway for higher education, one of the few in the country available for deaf students. A donated, purpose-built campus with residential facilities in Rashidabad, Sindh, serves as a national center of excellence for both deaf education and teacher training. And all students are given a healthy lunch daily, improving their nutrition and well-being. Daily transport is provided to all students within a 50-kilometer radius. Deaf Reach schools foster a holistic learning approach, providing an enabling environment where students can excel, attaining fluency in 3 languages: sign language, English, and Urdu. In addition to academics, each student receives training in a variety of skills. Extensively to reinforce learning. Deaf Reach created the first ever Pakistan Sign Language digital resources, available free of cost and providing unprecedented access countrywide to language and literacy skills development for educators, deaf children, and their families. Deaf Reach is invested in teacher development, facilitating high-achieving students to pursue a career in deaf education and positions of leadership. Over 50% of Deaf Reach's teaching staff and management are themselves deaf. Parents and family members are provided transport to attend bi-weekly sign language and literacy classes, enabling them to be active participants in their child's development, as well as to improve their own literacy skills. Working closely with the corporate sector, Deaf Reach delivers a full circle of opportunity for young deaf adults by providing training in marketable skills and facilitating employment. To date, over 1,000 deaf youth have entered the job market as a result. All deaf children in Pakistan deserve the opportunity to learn to communicate in their native language and to receive an education that will empower them to achieve an improved quality of life. With your support, we can make education a reality for deaf children in Pakistan.
We have just opened a school in Sujawal, so now it's 8 campuses. और सब कैंपसेस में फ्रॉम क्लास KG टू ऑल द वे BA तक क्लासेस जो है वो एजुकेशन दी जाती है, उसके साथ वोकेशनल स्किल्स ट्रेनिंग प्रोग्राम भी है. सो जल्दी से स्लाइड्स को जो है वो कैंपसेस को मैं आपको दिखाऊंगी. ये सब कैंपसेस जो है वो पब्लिक प्राइवेट पार्टनरशिप के ऊपर बेस्ड हैं और इन सपोर्ट विद गवर्नमेंट. और वी डोंट ओन दीज बिल्डिंग्स और वी डोंट पे रेंट फॉर दीज, और दीज आर ऑल विद पब्लिक प्राइवेट पार्टनरशिप. कराची हेड ऑफिस, Hyderabad, Nawabshah, Sakkar, Sujawal, Rashidabad, inside Rashidabad, Jhelum, and Lahore campus. We have IT lab, और in the afternoon we have 25 deaf adults जो कि IT की ट्रेनिंग के लिए और बेसिक लिटरेसी प्रोग्राम की ट्रेनिंग के लिए आफ्टरनून में आते हैं. सफाई स्टिचिंग यूनिट, किचन, culinary arts की ट्रेनिंग. These are some of the statistics. जुलाई 2020 से डेफ रीच लाहौर कैंपस स्टार्ट हुआ था और उसके बाद ये सब विजिटर्स लिस्ट और प्लेसमेंट, स्टूडेंट्स पॉपुलेशन. क्योंकि डेफ एम्प्लॉयमेंट के ऊपर भी काम किया जाता है, तो ये कुछ कंपनीज हैं जिन्होंने डेफ एम्प्लॉयमेंट जो है उनको सपोर्ट किया है और हम काफ़ी जो है डेफ को एम्प्लॉय जो है हायर कर चुके हैं इन कंपनीज में, जिसमें सर पहले सफायर फिनिशिंग मिल है जिसमें 2020 से 2022 तक अभी तक 154 जो कि हैं वो टोटल प्लेसमेंट्स हो चुकी हैं. वॉलंटियर प्रोग्राम पिछले 2 सालों में हम 2 दफ़ा समर कैंप और एक जो है वो आई कैंप, डेंटल कैंप अरेंज कर चुके हैं. दीज आर सम द वॉलंटियर. साइंस फ्यूज एक ऑर्गेनाइजेशन है, प्राइवेट ऑर्गेनाइजेशन जो कि एवरी ट्वाइस अ वीक कैंपस में आती हैं प्रैक्टिकल साइंसेस की क्लासेस के लिए. और थैंक यू सो मच.
We'll teach you one more sign.
Yes.
Thank you. Shukriya.
Okay, one universal sign. I. L. Y. I love you.
Thank you very much.
For your valuable information and we appreciate your valuable contribution. 607 जो है गाड़ी किसकी है? अगर किसी को बहुत ज़्यादा क्वेश्चन आ सकते हैं तो बता दें, अगर नहीं तो we can wind up. So thank you so much. We have wonderful talks, starting from Dr. Kavinda Dugal, who enlightened us about nutrition, obesity, followed by Professor Farooq Afzal, sharing his personal experience of bariatric surgery. Then we have a wonderful talk of Professor Yasun Nabi Tayyab, Professor Dr. Afzal Alam, and Mr. Daniel. I would say, listening to Afzal Alam and Daniel, अकेला ही चला था जान ले मंजिल मगर लोग साथ आते गए रात ना बदला गया. And the take-home message of today's session is, don't be afraid of your dreams. Don't be afraid of the space between your dreams and reality. If you can dream it, you can achieve it. So, dream big, work hard, stay humble, and thank you so much. We expect you in auditorium at 11:30 after the tea. Thank you.
Coffee as well. Or I would like to ask a question, as we've seen your experiences from UK, US and from Pakistan. If you look at the data that is available on internet, we see that the number of patients in UK and US are a lot more as compared to Pakistan, but the number of deaths in Pakistan are very less. The person care provision or the data is not completely shown, or any other, or the treatment was initiated with less restriction. What are your views on that?
Thank you. I think this is a very commonly asked question. So there are various factors in it, really.
Coordinated care and integrated care. And but in Pakistan, most of the care, especially taking over, giving over, handing over, is not that robust. So care becomes fragmented. Everybody puts her own effort very diligently, but the coordination is not that good. So how is this coordination maintained in UK, and what Pakistani government is going to do in our hospitals to improve the coordination? We go on just paper and pen, write calls, somebody receives calls, doesn't receive calls, somebody hands over, somebody doesn't take over. So how this problem should be taken over? Thank you.
Obviously, we are talking about totally different systems here. Really, as you know, during COVID pandemic, we work in NHS, where obviously people were getting paid, but many surgeries were cancelled. And can you imagine one of the thoracic surgeons, for example, there was a shortage of ITU nurses, so thoracic surgeries were not happening. In one area, Middlesbrough, one of the thoracic surgeons, he trained himself to be a nurse. So he worked on nursing shifts. So that was the level of collaboration in those hospitals. And believe me, some of the physicians who were not directly involved, they even mopped the floors, they cleaned the floors. So this is the type of collaboration. In our hospital, we developed a BASIS program, which was adopted nationally in UK. So what was that? What was that? I'm just giving you one simple example. So let's say I'm doing ward round. I go and see the patient. Okay. I will take the vitals of the patient. I will check saturation, I will check blood pressure, everything myself. Usually this is done by nurses or healthcare assistants. I will ask the patient, do you need anything to eat? If there is a tray there, sitting there, patient has finished eating, I will bring that tray with me outside. We shared our responsibilities with each other. We were all in it together, really. It was not like I'm a big consultant, you are a nurse, or you are a healthcare assistant. When it comes to specialty, really, I mean, we are really comparing apples with pears here. The people there have got very coordinated efforts. You get them and they will come. For example, in ITU care, one role which was adopted was that non-ITU physicians, they will take the job of updating the families. Every day at 3 p.m., non-ITU consultant will call the family or even get the FaceTime talk with the patient if they are awake, with the family, etc. Just to calm them down. Obviously, they are not allowed to come in, and they don't know what is happening. So we coordinated in many different ways. There are hundreds of examples of that. And when it comes to care, I think everything was available, and we were lucky to have that. I think Professor Mahmood can tell better from Pakistan perspective.
Now, this is a very tricky question. You asked something that has a lot of components, but your focus again, unfortunately, and don't feel offended, but this is my analysis, that our focus has always been on the government. Now, if you look at your question, what does it have? The content of the question is our moral, ethical responsibilities, our own responsibilities. I mean, where would anything other than morality come in, that you signed a thing for doing something and you don't want to do it? So what are the components do you have other than morality? So I think the reasons for that sort of understanding is bad education. What we call education is not actually education. We just qualifying people for getting a job. Education needs to change their thinking. Education needs to change their mind, their way of working. Unfortunately, जिसको हम तालीम कहते हैं हमारे मुल्क में वही नहीं करते. So our focus is not on making good human beings. So when you come to medicine, then this becomes a pertinent question. When you go to the traffic inspector, then that becomes a pertinent question कि वो traffic control करने में interested नहीं है, वो सिर्फ चलान करने में interested है. So this is unfortunately a moral degradation, and that makes you tread into areas that apparently are forbidden. But this is where we need to really work on. इसको आप हुकूमत को कुछ कानून नहीं बना सकते ना, बट वी फ्लाउट टू लॉ एवरी डे एवरीवेयर। तो ये मोरालिटी, ये एजुकेशन, ये सेंस ऑफ रिस्पॉन्सिबिलिटी, ये आएगी जब लोगों का बिहेवियर, उनकी सोच, उनका एटीट्यूड बदलेंगे। जो मैंने एटीट्यूड की बात की थी ना, दिस फॉल्स इनटू द एम्बिट ऑफ द एटीट्यूड। इफ आई गेट अ कॉल एंड आई एम नॉट कंसर्न्ड, so how does the law become involved? It's humanity, it's your morality. तो ये वो चीज़ें हैं जो हमें अपने तालीमी निज़ाम में लानी पड़ेंगी, रोल मॉडल करना पड़ेगा। अगर आप मुझे सारी उम्र देखते रहेंगे कि मैं तो ये नहीं करता, you learn something from me। अगर आप मुझे सारी उम्र ये देखेंगे कि मैंने तो कभी मरीज ही नहीं था देखा कोविड में, तो फिर आपका भी वही ट्रेनिंग होगी। So training is, a lot of training is formal, but much more than formal training is the informal learning that you have on your talks and visits and by looking at the people who are role models. So unfortunately हमारी society में ये 3-4 चीजें हैं जो नहीं है, and unless we have them, there is no answer to your question.
Thank you sir for your keeping this thing in mind. I would request, we have introduced student chairs from this annual conference. So I'll request our student chair, Dr. Maria, to please give your views. Being a fellow in internal medicine, what are your views about the COVID pandemic and about this session?
I would like to thank Vice Chancellor Professor Khalid Kandil and Professor Bilkis for giving me the privilege of attending this session as student chair. And it had been a great privilege learning from the experiences of all of the experts in the field regarding managing pandemic in different institutions in different geographical regions. As myself working in, I have worked myself in the COVID ICUs. So I think one thing that we need is the more inclusion of ICU care, family medicine, and including telemedicine in the future in our curriculum and in our part of as a training, which has been lacking in the past. Thank you.
Thank you very much. Now I will request our HME chair, the Vice Chancellor Professor Khalid Kandil for his views.
Bismillahirrahmanirrahim. And thank you, Bilal. I think we had a very productive and wonderful session today. Bilal has handled the session, and then the speakers, they talked about the COVID-19. Dr. Asim Siddiq, Professor Bilkis Shabib, Iqbal Sen, Dr. Arshad Taki, Professor Mahmood Shakar, and Dr. Faisal Sultan. And there were 4 parallel sessions. In auditorium we had the session about the critical care invented there. And similarly, in the medical education department, another important session was going on, occupational health and the role of general practitioner, and how we are going to develop the family medicine system, the referral system in Pakistan. So, I think we are ending up with these 4 parallel sessions, and in the concluding session, all these 4 sessions, they are going to be here in the auditorium, where I could see Hamid Atiq has already reached. Faisal Sultan is going to join us shortly. Dr. Ahmed Saeed and Dr. Salwa, they will be there. And in the next 10 to 15 minutes, we can stretch the legs. And there is a poster exhibition going on. Dr. Bilkis is going to tell us what we are going to do next 10 minutes. And then we will get together here again at 11:35 for the concluding session. So over to Professor Bilkis.
Thank you very much.
Thank you so much, sir. And first of all, I'm very, very grateful to the worthy speakers and extremely impressed by their talks. And they were really all very, very fascinating exchange of experiences. And review of what we did right and what we did wrong, and the critique on how we can, improve upon it. So thank you very much, and inshallah we'll be heading on towards the next session. The next session is also going to be very interesting. It's a COVID debate, and it would be held in this very hall. Till then, we would be requesting all the chairs of the various sessions to kindly join us at the poster competition. Dr. Adar Said is probably in another session. Dr. Adar Said and representing KEMCA UK and FJK UK has involved Fatma Jinnah Medical University and King Edward Medical University in poster exhibition of various subjects. And our Vice Chancellor was very generous in announcing that the Fatma Jinnah Medical University winners would be getting prizes. So, inshallah, the first prize would be 30,000, the second prize would be 20, and the third would be 10. So, inshallah ta'ala, probably the students have had a look at the posters. We would request you to keep seated there. We'll show the, or you can, sort of stretch your legs, as Sir said, and we'll come back and join the auditorium at 11:30, following the poster. Thank you so much.
Thank you. So reach now back here at 10:35.
जितने भी कैमरा मैन हैं सब यहीं पे इकट्ठे होने वाले हैं। आखिर में मैं तो इतने इकट्ठा होया था। हाँ नहीं यार और तेरा ऐसे स्टैंड से उठा करो ना बड़ा करके ना रखो।
ये कोविड हीरो है। आप बिलीव करें कि आपका इंटेंसिव केयर में होगा और आपका गंगाराम का इंटेंसिव केयर, आपको पता है कि ये पेशेंट पॉजिटिव है और ये कफ कर रहा है और आपने इस पेशेंट को ट्रीट करने के बाद, देखने के बाद, यू आर गोइंग टू सी योर किड्स, यू आर गोइंग टू सी योर ओल्ड पेरेंट्स। लेकिन इस तमाम के बावजूद नॉट अ सिंगल डॉक्टर रिफ्यूज और ये सारे फ्रंट लाइन हीरो मौजूद है वहाँ। और ये क्रेडिट की तमाम को जाता है। बात यही नहीं है कि आप शोहदा की बात करें, आपके यंगस्टर डॉक्टर से लेकर पैरामेडिक्स, नर्सेज, टू द एक्सटेंट ऑफ द वाइस चांसलर, वी लॉस्ट प्रोफेसर मुस्तफा कमाल पाशा, कोविड हीरो। तो ये कुर्बानियां दी और पाकिस्तान का कोविड में एक ऐसा नाम आया कि पाकिस्तान बिहेव अ बेटर। एक मेरा थोड़ा सा इस बात पे इख्तिलाफ था, अभी जब प्रोफेसर बिल्किस बात कर रही थी कि पाकिस्तान में बेहतर होने की काफ़ी वजूहत है, वैक्सीनेशन भी है, मेलिएबल होना भी एक है, फैसल सुल्तान साहब ने टीम की भी बात की, लेकिन मेरे अतर साहब एक और भी है कि पाकिस्तान एक वाहिद मुल्क था पूरी दुनिया में जहां मसाजिद को बंद नहीं किया। तो सेहत तो सारी अल्लाह की तरफ से है। जब मस्जिद में नमाजों का सिलसिला जारी था और दुआएं जारी थी तो अल्लाह का शुक्र है कि पाकिस्तान जैसे जैसे दिन गुजरते गए, कोविड में पाकिस्तान का नाम पूरी दुनिया में एक यूनिक कंट्री के तौर पे आता गया। और इसमें भी मैं समझता हूँ कि हमारे बड़े, उनका भी बहुत बड़ा रोल है। और प्रैक्टिकली अगर हम देखें तो पाकिस्तानी कौम ने एज ए नेशन बिहेव किया। गवर्नमेंट का अपना रोल, मीडिया का अपना रोल और फ्रंट लाइन वर्कर डॉक्टर्स का अपना रोल, नर्सेज और पैरामेडिक्स का अपना रोल। तो ये टीम स्पिरिट थी जिसके साथ ये रिजल्ट आया। और कुछ इनोवेशन जो इस मौके पे थी, आई मस्ट मेंशन वन थिंग along with all these things is the concept of teleconsultation। चौधरी सरवे साहब ने कहा कि टेलीकंसल्टेशन स्टार्ट करें। किंग एडवर्ड में हम लेके आए, 20,000 से ज्यादा लोगों ने इस्तेफादा किया, 80,000 से ज्यादा लोगों ने कॉल्स की, 35 से ज्यादा ममालिक थे वहाँ कॉल की। एडान दुबई एक्सपो दिस वाज डिक्लेयर्ड एज वन ऑफ द बेस्ट प्रोजेक्ट। और कई नई चीजें हम सीखे हमने। और फिर आई मस्ट गिव क्रेडिट टू माय एलुमनाई, हमारी कैंपा यूके और हमारी जो फातमा जना they remain in touch. रिसोर्सेज के साथ अभी तस्करा हो रहा था कि इंटेंसिव केयर में अगर पेशेंट लियो में मौजूद है तो आसफ तुफैल पूरी टीम के साथ यूके में बैठा हुआ है, एक पेशेंट पे डिस्कशन हो रही है। तो पाकिस्तान की आवाम के साथ हमारी एलुमनाई का भी बहुत बड़ा कनेक्ट था। आई एम श्योर गुरीजा, प्रोफेसर जोरा, बिल्किस जबीर, इमरान असलम, ये अदर साहब सारे लोग परसों ट्रैवल करके गए। आकाशानी विलेज, फाजिलपुर तहसील, राजनपुर जिला, फातिमा जना मेडिकल यूनिवर्सिटी, पहली यूनिवर्सिटी जिसने मेडिकल कैंप लगा के इमीडिएट लीव किया और साथ उन्होंने कहा नहीं रिहेबिलिटेशन। तो एलुमनाई की मदद के साथ 29 घरों को इनॉग्रेट कर किया है, कम्युनिटी सेंटर और डिस्पेंसरी वहाँ इनॉग्रेट करके। और रात जब हम 12 बजे यहाँ पहुंचे तो चारों हॉल में 8:30 बजे सेशन जारी थे। आई थिंक दिस इज फातिमा जना, दिस इज द स्टूडेंट्स ऑफ फातिमा जना एंड फैकल्टी ऑफ फातिमा जना कि ऑर्गेनाइजर 12 बजे आ रहे हैं और ऑर्गेनाइजेशन पहले ही हो चुकी थी। अतर साहब आपका भी बहुत शुक्रिया, आपने मौका दिया फातिमा जना को एक हाईलाइट करने का, शेयर करने का, और जितने आपके स्पीकर्स थे आई थिंक वी हैड अ वंडरफुल टॉक। थैंक यू सर, थैंक यू वेरी मच, थैंक यू।
थैंक यू खालिद। एक्सपीरियंस और इन्वॉल्वमेंट थी कोविड की पैंडेमिक के दौरान, मुख्तसर समरी बताइए 2-3 मिनट में, फिर हम आगे से तफसीली सवाल आपसे पूछेंगे फॉलोअप में।
जी थैंक यू मच, थैंक यू डॉक्टर सर। जो फर्स्ट पीक आई है हमारे पास कोविड की, दैट इज जून 20 से लेके मार्च 22 इंडस्ट्री आई वाज प्रिवी टू एनसीओसी की फॉर्मेशन और सारी चीजें हैं। प्रोफेसर सुल्तान ने बताया फर्स्ट सक्सेस सबसे बड़ी है, और तो फ्रंट लाइन में रियल सोल्जर्स तो आप लोग फाइट किया। देयर वाज सप्लाई चेन प्रॉब्लम्स, ऑक्सीजन की प्रॉब्लम थी, हमारे पास कैपेसिटी का इशू भी था, उसके बाद टैंक्स के इश्यूज थे, उसके बाद वैक्सीन के आने का इशू था, उसकी स्टोरेज का इशू था, रेमडेसिविर एक वक्त में बड़ी शोर मच गया कि वो होनी चाहिए। तो इसके लिए जो सबसे अच्छी बात हुई थी वो चूँकि सिंध वॉज नॉट कोऑपरेटिंग विद द फेडरल गवर्नमेंट, एक हमारी बदकिस्मती है। तो आर्मी स्टेप्ड इन, जनरल सती और जनरल जोराया जो थे अलॉन्ग विद असद उमर साहब और उस वक्त के प्राइम मिनिस्टर ये डिसीजन किया कि लेट कोर्ट ये एडमिनिस्ट्रेशन शुड बी मैनेज बाय असद उमर साहब एंड जनरल सती। और वो इतना अच्छा उसका इम्पैक्ट आया कि सब लोग उनकी बात सुन रहे थे, और ये कोऑर्डिनेशन जो है इतनी मुश्किल, इसकी डिटेल्स अभी आगे आएंगी, बट इट वाज वेरी डिफिकल्ट पीछे कोऑर्डिनेट करना, जो सारा सामान मुहैया होता रहा। और दैट इज व्हाई ऑक्सीजन वाज शॉर्ट इन इंडिया, और हमने उनको 1-2 दफ़ा ऑफर भी की कि हम आपको भेज देते हैं, लेकिन इट वाज नेवर फॉर अ डे भी यहाँ पे शॉर्ट नहीं हुई है। नॉर्दर्न इलाकों से लेके यहाँ तक ना ऑक्सीजन शॉर्ट नहीं है। वैक्सीनेशन का भी हमारा जो है मतलब जिस वक्त कहा गया कि 60 से ऊपर लोगों को लगेगी, उस वक्त जितना मर्जी को सिफारिश कर देता था फेडरल गवर्नमेंट ने, नहीं लगती थी उससे नीचे वालों को। सो देयर कैन बी मेनी लेसन जो कि इससे लर्न हम कर सकते हैं, एंड इट इज अ सक्सेस स्टोरी, और मैं इसको लिखा जाना चाहिए कि कितनी कामयाबी से पाकिस्तान ने इसको मैनेज किया।
जी शुक्रिया हामिद। तो अब हम बारी थोड़े से ज़्यादा तफसीली सवाल पूछते हैं। पहले 3 सवाल मैं पूछूंगा और उसके बाद ओपन टू द हाउस। तो फैसल, पाकिस्तान के बारे में ये कहा जाता है कि वी गॉट अवे relatively lightly as compared to the rest of the world, और we actually went against the world wisdom at that time, including the WHO advice that we should lock down, and when the whole world was locking down, we were actually opening up. And there was, incredulity and disbelief across the world कि हम लोग क्या कर रहे हैं, और क्या हमारा वही हाल होगा जो कि यूरोप में लोगों का हो रहा था। So what was it that got us through this pandemic relatively lightly? Was it just dumb luck, or was it smart policies? Was it cleverness, or was it just a miracle by, because we are good people?
Never discount luck, dumb or smart. But I think आपने जो बात कही है ये बड़ी इंटरेस्टिंग है और ये दुरुस्त है कि चाइना, वुहान, शट डाउन, लॉकडाउन, क्लोज डाउन वगैरह वगैरह, उस सूरत में टू गो अगेंस्ट दिस टाइप took something, और it took a toll to be perfectly honest. मैं आपको 2 एस्पेक्ट से बता देता हूँ। एक हुकूमत की पॉलिसी क्या थी और एक मेरी ज़ाती सोच इसके बारे में क्या थी। हुकूमत की पॉलिसी बड़ी क्लियर थी, और वो ये थी कि आप रखना इसमें कोई शक नहीं कि आपने इंटेंस वो एक्टिविटीज जहाँ इंटेंस इंटरमिक्सिंग हो रही है, जहाँ बहुत गुंजान सिचुएशन है, ऐसे इस कमरे में है, क्योंकि हमारा मॉडल ना उसमें से स्ट्रक्चर्ड है कि लंबा स्टैंड स्टिल बर्दाश्त करें, बल्कि आज आपके सामने बात है चाइना का डायलेमा देखते हुए कि उस किस्म का स्टैंड स्टिल जो था वो कोई इतनी अकल की बात नहीं थी। लेकिन क्योंकि वो उस वक्त जमाने खल्क थी, उसके खिलाफ जाना बहुत मुश्किल था। मीडिया, ऑपोजिशन, हर किस्म का एक्सपर्ट वर टॉकिंग अगेंस्ट इट। खालिद आपने जिक्र किया बंजुना का, हमारे अपने अजीज दोस्त जानने वाले जिस तरह से बैठना तो आपको उसे आसानी हो जाती थी फैसला करने, तो किसी रीडिंग पोजीशन को लेना है तो इसकी आपको एक मिसाल देता हूं, मास्क का इस्तेमाल, you know there was a lot of discussion करना है pro anti, we were actually, to be honest, one of the things that we were slightly slower in adopting, slightly, was mask usage। और मैं ज़ाती तौर पर confess है, मेरा ये ख्याल था कि मास्क यूजेज फ्रॉम द पॉइंट ऑफ व्यू ऑफ प्रोटेक्टिंग योरसेल्फ, बिकॉज़ अपने मुंह पे अगर आपने रखा हुआ है तो कम से कम आप बाकियों को उजागर करके रखें। And then of course eventually WHO, CDC, everybody came around to mask। मेरा ख्याल है कि coherent decision making based on data as it evolved and involving all arms of the government। खालिद ने बड़ा अच्छा कहा, चाहे provinces थी, चाहे ministries थी, अब डॉक्टर साहब बैठे हैं, he's not taking enough credit, मैं आपको बताऊं, मैंने शुरू सुबह के सेशन में इसका जिक्र किया था, अगर उस वक्त ऑक्सीजन की कैपेसिटी को एड्रेस ना किया में ऑक्सीजन शॉर्ट होती, इसके लिए को पता नहीं कितने तमगे दिए जाने चाहिए, लेकिन हम शायद स्लो भी हैं, हम इतने अच्छे नहीं अपने लोगों को रिकॉग्नाइज करने में, लेकिन ये बिल्कुल फैक्ट है कि अगर उस वक्त 66% ऑक्सीजन का इंक्रीज हमारे सिस्टम में इंजेक्ट ना हुआ होगा तो सब्सिक्वेंट हर वेव के अंदर हमें ऑक्सीजन की शॉर्टेज होती है। मुझे कैसे पता है? क्योंकि हमें सब्सिक्वेंट वेव्स में जो डेली कंजम्पशन इन मीट्रिक टन्स है वो हमें पता है, और वो उससे ज्यादा है जो हमारी टोटल 12 साल लग जाएंगे वैक्सीन लगाने। तो उस डिसबिलीफ और निहिलिज्म अंदर भी था, अपने सिस्टम में भी था, लोगों को समझाना पड़ा कि जब आप अपने घर से चलते हैं तो पहले 2000 मील आपका जो स्पीड होती है वो चंद मील बराबर होती है until you hit the bigger speed। Finding vaccine in a seller's market was one of the hardest things to do। आप एक चीज के पीछे है जिसके पीछे सारी दुनिया है, और आपका सिस्टम परचेज का ऐसे है कि वो कहता है कि ये पेन और कलम के ऊपर भी नैप केस हो जाता है, तो आपका सिस्टम इतना अवर्स था, घबराता था डिसीजन मेकिंग से कि ये कैसे खरीदे, जबकि ओपेक डिसीजन मेकिंग सारी जो परचेज थी वो सारी ओपेक। तो इसलिए इस सारी चीज को भी एक ट्रांसपेरेंट तरीके से करना और ऑक्सीजन आना, दैट वाज स्टेप 1। दूसरा, और ये सारा क्रेडिट हमारे सिस्टम को जाता है, लेकिन एक दिन डिस्कशन हो रहा था तो असल वर्ड से वैसे तो मैं अंदाजा है कि दिन में 2.5 लाख वैक्सीन लगानी पड़ेगी आपको एडल्ट्स में। हमारे मुल्क में तो हमने एक वैक्सीन नहीं लगाई थी एडल्ट्स को, हमारी तो सारी वैक्सीनेशन होती बच्चों को, तो हमारे सिस्टम को आदत ही नहीं थी वैक्सीन लगाने। तो मैं चुप हुआ, कुछ मैंने कहा अच्छा हाँ सही है देखते हैं। तो आपको मालूम है कि ऑन पीक डे हाउ मेनी वैक्सीन वर यूज्ड इन पाकिस्तान? पीक डे 2.3 बिलियन, जहां 2.5 लाख को वो हो रहे थे वहां 23 लाख। आपको मालूम है इसमें सप्लाई चेन अनलॉक हुआ, कोल्ड चेन एनेबल हुआ, स्टाफ ट्रेन हुआ, वैक्सीन की अवेलेबिलिटी हुई, आईटी बैकबोन उसके पीछे बनी, और आप सब गवाह हैं कि एट द एंड ऑफ द डे ऑल ऑफ अस हैड टू हैव इट इन अ सर्टेन rhythm and timing। So it's a lot of credit to the people of this country। So yes, dumb luck or wise luck, but I think a lot of thinking went into it। One last bit, people used to laugh on the smart lockdown business, but I tell you, अगर इस कमरे को उस कोने में थोड़ा खासा आग लग जाए तो आप उधर हो जाएंगे, इस सारी बिल्डिंग को पीछे स्प्रिंकलर सिस्टम चला देंगे। तो this was the other argument that we constantly used, but at that time यकीन कीजिए the pushback was unbelievable। उस वक्त इस चीज को फैसला करना और इस पे डटे रहना took some guts, and I think you have to give credit to the Prime Minister Khan, he was very clear on his vision and stuck to it।
Thank you फैसल, अगर कोई फॉलो अप सवाल है तो आप कर सकते हैं, वरना मैं जी आप फरमाइए यंग लेडी विद क्लासेस।
So I have a question related to COVID की vaccine. So everyone was like some doctors were like corticosteroids आपको देने चाहिए, and on the hand like they were like corticosteroids नहीं देने चाहिए, and some were like it was actually a win-win situation कि हम लोगों ने दिए And in the same like situation, they were like initially हमें देना चाहिए था, बाद में नहीं देना चाहिए था. So can you just tell me कि what is actually like the right and like accurate policy कि हम लोग का ये decision अच्छा था या नहीं?
Again, दो situations होती हैं, and this is a very good question और ये मुश्किल सवाल है in some ways, but इसका जवाब in other ways आसान भी हो जाता है. पहली बात ये है कि जब आप डिसीजन मेकिंग करते हैं in the absence of good data, और इसके ऊपर पूरी साइंस है, people have studied this, कि जब आपके पास अच्छा डेटा नहीं है और आपके पास वक्त नहीं है उस डेटा को जनरेट करने का, तो फिर आप कैसे फैसला करें? वो एक तरीका होता है, वो एक सिस्टम होता है, एक सिचुएशन होती है. मुझे नहीं पता कि क्या हो रहा है, मगर उस मौके पे मैंने कुछ फैसला करना है. So in that situation, you take the safest path possible. वो अक्सर ब्लंट होती है, मुश्किल होती है, लेकिन वो वक्ती तौर पे आपको प्रोटेक्ट कर देती है. उसकी क्लासिक मिसाल, अगर एक एपिडेमिक हो रही है और आपको नहीं पता, तो वक्ती तौर पे सिस्टम को वक्ती तौर पे शट डाउन करके until you can get your head above it and see what's going on is over. दूसरी सिचुएशन वो होती है जहां आपके पास हार्ड ट्रायल डेटा या एम्पिरिक डेटा या एक्सपेरिमेंटल डेटा या साइंटिफिक डेटा आ चुका है. उस वक्त वो दूसरा काम करना बेवकूफा है. अब स्टेरॉइड्स का यूज इज अ क्लासिक एग्जांपल. लुक, जब ये डेटा नहीं था, आपने इस्तेमाल किया या ना किया, नो वन कैन फॉर यू. एक दफा जब वो ट्रायल आ गया, which actually categorically showed कि ऑक्सीजन, जो लोग ऑक्सीजन यूज कर रहे हैं उनको स्टेरॉइड देने से बेनिफिट है और उनके अलावा देना एक्चुअली डेट्रीमेंटल था. तो इस सूरत में फिर नाजायज तरीके से या ब्लंट तरीके से उस स्टेरॉइड की डिप्लॉयमेंट इज अनफेयर and unscientific and not a service. अब बात ये है कि कई बार लोग कहते हैं हमने ये कुछ नहीं पता चला, बिकॉज आप डिटेक्ट नहीं कर सकते. क्या आपने सिस्टमैटिकली सारी चीजों को कलेक्ट किया, और अगर आपने नहीं किया तो किसी ने उस ट्रायल में बड़ी मेहनत से, बड़ी तकलीफ से ये सारे पैरामीटर्स देखे, इकट्ठे किए, एनालाइज किए और उसको पीयर रिव्यू के प्रोसेस के थ्रू गुजारा और आपको जवाब बता दिया कि भाई उन लोगों को जिनको सिवियरिटी इतनी है दैट दे आर हाइपोक्सिक, वो ऑक्सीजन से बेनिफिट करेंगे, उनको ना रोकना, जरूर देना, और वो जो नहीं है उनको ना देना क्योंकि उनको मुमकिन है नुकसान हो. So I think the answer is very clear. Look at the recovery trial and gives you the answer.
Sir, like हम लोग मतलब we know के corticosteroids are basically anti-inflammatory, लेकिन we do know के immunosuppression का भी उसका रोल है. तो like मतलब but still like we knew के there were like some people जिनकी immunity as like.
Better hold the mic closer to your mouth so that everybody can hear you.
Okay, so the elderly people, they do not have that immunity, you know. So still we were giving the corticosteroids to them. So like, don't you think like it was not that much of a wise decision?
So again, sometimes we construct based on physiology and pathology. हम एक पैथोफिजियोलॉजी मंतक अपने लिए क्रिएट करते हैं कि यार यूं होना चाहिए, ठीक है? Think knowing all this, ये ऐसे होना चाहिए. अगर ऐसी चीज हो तो आज तक फिर किसी क्लिनिकल ट्रायल की जरूरत ना हो. This conversation or this logic holds when you actually don't have experimental data. अब उस सूरत हाल में एक एंटीवायरल को इस्तेमाल करना in the viral replication phase makes sense. एक एंटी-इंफ्लेमेटरी को इस्तेमाल करना destroyed by the actual science. ठीक, आपके सामने कितनी सरप्राइजेस है ना आईसीयू केयर में, पता नहीं कौन सी चीजें आई हैं जो पिट गई. लोगों ने H1A1 से लेके एंटी टॉक्सिन, अब आप लोग तो in my medical career I've seen at least half a dozen things come and go based on experimental evidence. तो जब वो सामने आ रहे तो उसको देखना जरूरी है. As देखिए डॉक्टर्स हम always have the bedrock of science in it if it is there. अगर नहीं है तो फिर वो जो decision making in the absence of data है, उस सूरत में आपको कुछ जुगाड़ करना पड़ता है. So once you have the information, time for जुगाड़ is finished, time for science starts. ये हमने बहुत अहम distinction रखी है. Thank you. I really appreciate your question. बहुत मेहरबानी.
जी, thank you very much. अगला सवाल है फारिक साहब से मेरा, और I would quite like a comment from Bilkis after that and also Fed. आपके और खालिद साहब के जब ये पीक पे थी पेंडेमिक, तो हमने ITK के बारे में कंबाइंड एंटिटी शुरू की क्रॉस फ्रॉम UK टू पाकिस्तान, और उसमें ऑडियंस के इंटरेस्ट के लिए बताऊं कि हम लोग केस प्रेजेंटेशन करते थे हर हफ्ते, और एक मीटिंग करते थे एक्सपर्ट स्पेशलिस्ट डॉक्टर्स फ्रॉम द UK इंक्लूडिंग IT फिजिशियंस, IT फिजिशियंस, और एक और पाकिस्तान से भी, और हम लोग अपना केस प्रेजेंट करते थे, ये लोग अपना केस प्रेजेंट करते थे, so that we could learn from one another in a situation which was kind of novel and unprecedented and a bit frightening. तो मैं ये पूछना चाहूँगा खालिद साहब से और उसके बाद बिल्किस और तुफैल से कि आपने उस एक्सपीरियंस से क्या लेसन्स लर्न किए जो कि आइंदा फ़ायदेमंद हो सकते हैं सर्विस डेवलपमेंट में। खालिद साहब।
थैंक यू वेरी मच। सबसे पहले वही बात जो प्रोफेसर ने भी की कि टीम और कलेक्टिव विजडम, इसका आई थिंक देयर इज नो सब्स्टिट्यूट। और इसमें पाकिस्तान में तो ऑलरेडी गवर्नमेंट ने ट्रेनिंग स्टार्ट करवा दी थी। हमारे वी हैड द मीटिंग, अपनी मीटिंग चल रही, लेकिन जब तुफैल साहब और आपने ऑफर की कि इंटेंसिव केयर की फैसिलिटीज हमारे और यूके की, आई थिंक देयर वाज लिटिल डिफरेंस। You had a little bit advancement. Later modern
एज स्ट्रेटिफाइड मोर्टेलिटी रेट हैं बिल्कुल वही थे जो सारी दुनिया में, कोई अलग नहीं, बिकॉज आप नेशनल लेवल पे कंपाइल कर रहे थे, आपके पास इंस्टीट्यूशन थे, कोई फर्क नहीं था। तो दिस ये सारी जो एक्सपर्टीज थी हेल्प इन डूइंग।
जी थैंक यू फैसल। बिल्किस आपसे भी मैं यही सवाल पूछना चाहूँगा कि क्या जो ITU के मैनेजमेंट थी उसमें आपके तजर्बे में और आपके ख्याल में कोई ऐसी चीज़ें हैं जो कि आपने और हम लोगों ने लर्न की जो कि हमारे अस्पतालों में अक्रॉस द बोर्ड फ़ायदेमंद हो सकती हैं?
Thank you so much, Dr. I'll be very honest. मेरा जवाब ऐसे साइड दे दिया है गुंदल साहब ने, because उन्होंने पूरे you remember the first few sessions were on discussion. We were discussing things, we were discussing SOPs. We were comparing the SOPs and the guidelines, your local guidelines. By that time, NCOC had come up with our local guidelines, and we were comparing, and we were sort of, coming up with an equilibrium. Generally, they were almost the same. I would say they were, Pakistani guidelines were compatible with those followed in UK or USA. But when, after the first 1 month, after 3 or 4 sessions, because we used to hold these sessions weekly on Saturday, 12 noon, you proposed to us to start presenting cases. And when I conveyed this to my teams, उन्होंने पता है पहले क्या कहा, लोग वो हमारी गलतियां निकालेंगे। अच्छा, we thought कि हमारी बहुत सारी गलतियां होंगी और जो कि थी भी, लेकिन somehow we felt कि ये जब तक आप अपनी गलती नहीं put forward करोगे, how would you learn? So when we were discussing cases, और फिर then they started enjoying it. वही लोग जो कहते थे ना, मैडम हमने क्या मुसीबत में डाल दी है, क्या आपने वो कर दिया, तो they started enjoying. And you remember कि हमारे audience बढ़ते गए. We used to go online. And we were not only department of the ICU or the medicine, we involved the anesthetists, we involved the microbiologists, we involved the psychiatrists. So different fora depending on the case, and the radiologists, depending on the cases we were discussing. So we started enjoying it. And I think it was a wonderful experience. I remember Dr. Asif Tufaila, he would also, in fact we were discussing it in the previous session just now, कि बहुत सारे cases होते थे when they would be presenting and our teams would be giving inputs, and we would be re-discussing the cases the next week, and in fact we would be following the patients up. और I congratulate the teams जिनमें हमने we were able to save lives because of your worthy suggestions and your worthy opinions. So it was a wonderful learning opportunity जहाँ कोविड ने हमें बहुत सारी चीजें सिखाई। उसमें एक बेस्ट चीजें थी, आई थिंक ये जो कम्युनिकेशन, जो टेली कम्युनिकेशन विद द पेशेंट्स, these webinars, these international seminars, जो मैं अभी गई थी कि बिल्कुल zero cost पे we were able to communicate with such experts like yourself and Dr. Asif Tufaila, Dr. Tabitha Dugal, and you guys were so cooperative and so collaborative about it. You were just a call away. I remember Dr. Tabitha को मैंने call किया था for international seminar, webinar, and she said, fine, वो time क्या है, तो वो जो time इनका था, that was very odd time. उनकी आंखें सूजी नहीं थी उस वक्त जब she was attending, because उधर कुछ बहुत early hours थे. But you were like, और अक्सर Dr. Asif, if I'm allowed to reveal, उनके बच्चे गोदी में बैठे होते थे कि यू आर अबाउट टू गो फॉर द आईसीयू, तो आप गिव अस सम टाइम। तो उनकी बेटी भी हमारे साथ अटेंड कर रही थी वेबिनार, शी विल बी गिविंग हर इनपुट, छोटी सी बेबी। सो इट वाज अ वंडरफुल एक्सपीरियंस।
जी थैंक यू बिल्किस। मेरे याद है कि तुफैल की बेटी और बिल्किस की बिल्ली दोनों अटेंड किया करते थे सामने। तो तुफैल आपसे भी मैं ये पूछना चाहूँगा कि
सिमिलरली जब हम हमारा यूके का वी शुड एडमिट के हमारा जो प्रिवेंशन और पीपीई का जो सिस्टम था वो नहीं था, वी लर्न फ्रॉम यू बेसिकली। सो इट वाज क्वाइट अ गुड म्यूचुअल लर्निंग। आई टेक इट फर्दर रियली। देखें हम हर साल दिसंबर में आते हैं, ये यूएचसी का प्रोग्राम 5 साल से चल रहा है और पीपल लाइक प्रोफेसर खालिद मसूद गोंदल दे वेलकम अस विद ओपन आर्म्स रियली and really enjoy it. And there are about 10 or 15 Cambodians who have come from UK who are here today, really, and we will be doing this symposia at KE as well. So, क्योंकि मैं तो इसको suggestion दूंगा कि ये इतनी fruitful चीज है कि इसको आप इस एग्जाम्पल को कैबका की और कैबो की और एनजे की कोलैबोरेशन को आगे लेके चले, इसको इंटरनेशनल लेवल पे लेके चले। इस तरह हमने कोई रोशन डिजिटल अकाउंट खोला है, हमने पैसे भेजे हैं यहाँ पे, आपको रोशन दबाव अकाउंट खोल लें, कुछ होना चाहिए। वी आर हियर टू हेल्प रियली, वी आर हियर टू कोलैबोरेट एंड यू विल नॉट बिलीव मी रियली कि यूं ही हमने एक कॉल भेजी अपने व्हाट्सएप ग्रुप पे कि भी हमने इस तरह कोलैबोरेशन करनी है केई के साथ। रियली किसी ने, मुझे याद है कि हम में से किसी ने 8 बजे अपनी ड्यूटी भी करनी होती थी, तो हम 6 बजे पहले उठ के सबसे पहले ये एडमिटी मीटिंग करते थे, उसके बाद अपनी ड्यूटी पे जाते थे। बाकी जो क्वेश्चन है आईटीयू की केयर का, आई थिंक वी आर नॉट कंपेयरिंग एप्पल्स विद एप्पल्स। आई मीन there are many differences, data collection, etc., etc. I will leave it for some other time. लेकिन Dr. Arshad Taqi की talk थी सुबह quality parameters पे, so I think there are good things happening here. We are on the right track, and there were some very good suggestions made in the morning session. PPT की specialty बननी चाहिए, हमारे quality parameters होने चाहिए, और ये चीज़ें मेरे ख्याल में बहुत ज़रूरी है। I think there is a lot which can be done in critical care medicine in Pakistan, and we will improve it, and we are here to help. Thank you.
Thank you, Tufail. So अगला सवाल मेरा हामिद से है। Hamid has told me a story about the oxygen supplies across the country. इसका फैसले जिसका जिक्र किया, and I think it was quite massive achievement. क्योंकि मुझे पता है और आपको पता है कि जो वेंटिलेटेड पेशेंट्स थे उनकी आउटकम इतनी अच्छी नहीं थी पाकिस्तान में, और जो की इंटरवेंशन थी that was oxygen nitroxones की availability. So the unsung hero of this episode, I can assure you, is Hamid Ali. So therefore, we should express our gratitude and admiration for his understanding and for his operational capabilities. So Hamid, tell us a story in some detail.
छोटी सी story detail again. Was not me alone, team थी हमारी, लेकिन this was a few good men with innovation. क्योंकि हम जब निकले हैं फर्स्ट वेव में और हमें अंदाजा हो गया कि हम कैपेसिटी को टच कर रहे हैं, मतलब 470 टन की आपके पास कैपेसिटी थी, प्रोडक्शन असल में 450 थी। और जब हमने ऑक्सीजनेटेड बेड का हिसाब लगाया तो 24,500 कुछ थे। ऑल्सो लकीली नेवर टच दैट फिगर ऑफ 24,000। हमारे 5, 6,000, 7,000 से ज़्यादा क्रिटिकल पेशेंट पाकिस्तान में किसी वक्त भी नहीं रहते, लेकिन नेवरदलेस वी वर मतलब बहुत ज़्यादा खौफ में थे कि अगली वेव में हमारा क्या बनेगा, ये इस वेव में क्या होगा। एंड द वेरी फर्स्ट डे आई वेंट टू द फाइनेंस सेक्रेटरी और उनसे पूछा कि को पैसे हैं, उन्होंने कहा कि हमने 3 बिलियन वैक्सीन के लिए रखा हुआ, आपके लिए पैसे बेहतर है कि आप खुद ही कर लें। और इट वॉज अ ग्रेट चैलेंज कि अब इसको पैसे भी नहीं है इस पर लगाने। सो हमने कैपेसिटी भी बढ़ानी थी और पैसे भी लगाने थे। आप लोगों से शायद मुतल्लिक इतना ना हो, बट देयर वर 3 or 4 प्लेयर्स। एक रनी ग्लास वाले हैं लाहौर में, ये बनाते थे। एक पाकिस्तान ऑक्सीजन लिमिटेड है कराची की, वहाँ बनती थी। और एक नए अपकमिंग मुल्तान केमिकल्स थे जो कि फैसलाबाद और मुल्तान में प्लांट था। एक शरीफ केमिकल थे जिनका एक लाहौर में और हतार में प्लांट था। ये टोटल प्लेयर्स थे जब इनके साथ डील कर रहे थे। इनसे हमने पूछा कि जनाब आपको क्या चाहिए, हमारे पास पैसे नहीं है लेकिन हम आपकी हेल्प करने की कोशिश करेंगे, कैपेसिटी बढ़ाने की। इसने बताया मुझे रनिंग क्लास वाले ने कि हमारा एक 200 वाला प्लांट जो है ना वो चाइना में है और वो आ सकता है, वो फर्ज कीजिए कि 6 करोड़ का है और उसके ऊपर 4 करोड़ की टैक्सेस एंड ड्यूटीज हैं। मैंने कहा कि आपको 4 करोड़ की ड्यूटियाँ छोड़ दें तो आप ले आएंगे कल परसों तक या कर देंगे शिपिंग हो सके, कहते नहीं हम कर गवर्नमेंट ऐसा इशू कराया, उनकी ड्यूटियाँ वेव कराई और हमने वो प्लांट का जिस तरह से। उसके बाद एक उनका प्लांट था, उसकी तार पड़नी थी, प्रॉब्ली 90 to 100 मीटर्स की तार जो थी वो पता नहीं कब से एनर्जी के डिपार्टमेंट में लेस्को में पड़ी हुई थी जो नहीं कोई डालते थे। उनको रिक्वेस्ट की, मतलब हमने सिर्फ ये किया कि जो एग्जिस्टिंग और ये पीओएल का इसमें नॉर्थ साउथ में बड़ा प्रॉब्लम था। यानी हमारी स्टार्ट थे आपसे पहले 2/3 कराची में थी, 1/3 लाहौर में। लाहौर हमें जो थे क्रायोजेनिक टैंक्स में है और कराची सेल्फ सफिशिएंट, और बाद में प्रूव भी ये हुआ 4 वेव्स में कराची का स्टोरेज हमेशा ज़्यादा रहता था और यहाँ पे हो रहा था सारे के सारे। सो व्हाट वी डिड वाज कि उनको हमने इधर शिफ्ट करना शुरू किया कैपेसिटी को, और एट द एंड ऑफ द डे सितंबर जो है उसमें हम 804 में से 500 की कैपेसिटी लाहौर और पंजाब में थी और 300 उधर कराची में वहाँ रही। सो यहाँ से हमारी जो ट्रांसपोर्टेशन थी उसमें कई दफ़ा जब पीक आई थी सबसे बुरी हमने फेस किया मई 21, ये ईद के दिनों में हमें मिश्रिशा और गिडानी को बंद करना पड़ा, इंडस्ट्रियल यूजेज उसका उधर से 100 मीट्रिक टन की हम सप्लाई अस्पतालों में डाली बिकॉज भी, और हमारे पास कोई और ऑप्शन नहीं रहा था। उन बुरे दिनों में भी जो था ना हमने सप्लाई अपनी जारी रखी और उसमें थोड़ी सी हमें साउथ से मूवमेंट करनी पड़ी, अदरवाइज हमारे ट्रक कई दफ़ा 3 दफ़ा भरने के लिए जा रहे थे बिकॉज इट वॉज ईजी, गुजरावाला भेजना था तो गनी वाले के प्लांट से रायगढ़ से वहाँ तक भेजना इट वॉज नॉट डिफिकल्ट, 3 से करने लगे। तो हेंस इट वॉज सारी की सारी इनोवेशन साउथ और नॉर्थ की डिस्ट्रीब्यूशन को ठीक करना, और इनके छोटे छोटे प्रॉब्लम में ये भी करना पड़ा कि इनके जो एग्रीमेंट्स हुए थे वो यहाँ पे 30 रुपए पे हुए थे सारे, फातिमा जना इधर उधर जो थे 30 रुपए टन गैस इनकी थी, और प्राइवेट सेक्टर में जो नीडल चीफ दे रहा था इनको वो 100, 110, 120, 150 तक। तो ये इनकी टेंडेंसी आखिरी बिजनेस करने को फिलैंथ्रोपिस्ट तो नहीं थे, ये उनको ज़्यादा सप्लाई कर रहे थे, इधर रोक रहे थे। इधर हमारे खैर से नो हॉस्पिटल का बिल ही क्लियर हो रहा था उनका, वो जैसे हमारे लोग चेक लीजिए ऑफिस में रोक के बैठ जाते हैं तो वहाँ 6-6 महीने से पैसे पड़े हुए थे। तो ये केम टू पंजाब चीफ सेक्रेटरी के साथ मिलके और इस तरह सिंध में जाके क्लियर पैसे, हमने कहा ये फर्स्ट प्रेफरेंस है हमारी इनको, और उसके बाद हमने मई से लेकर सितंबर तक वहाँ एफबीआर के आर्मी के लोग भी बिठा दिए कि ये सिलेंडरों वालों को ना भेजें और लिक्विड ऑक्सीजन की सप्लाई बरकरार है। दिस इज अ हीरोइक एफर्ट ऑफ फ्यू गुड पीपल जो कि हमारी टीम में थे। एंड हमने, मुझे याद है एनसीओसी की मीटिंग हो रही थी तो असद उमर साहब ने मेरे को देख के कहा कि जनाब देखो ये शॉर्ट हो जानी है तो इम्पोर्ट कर लो ऑक्सीजन। मैंने उन्हें कहा कि आपके ऑक्सीजनेटेड बेड जितने हैं आपके बेड्स पहले खत्म होंगे, हमारी ऑक्सीजन बाद में खत्म होगी।
जी बहुत पहला तो अंग्रेज बहादुर ने जो 19वीं सदी में सिस्टम बनाया था उसके प्रोडक्ट हैं आप भी और हम भी और हाफिज साहब भी, लेकिन जो आयरन ग्रिड ऑफ द एम्पायर था उसको ये टैक्सेशन डिपार्टमेंट और डेप्टी कमिश्नर चलाते थे। इट इज अमेजिंग टू सी कि देयर आर स्टिल अ फ्यू गुड पीपल अराउंड with the understanding and with attention to detail, जैसे कि आपने point out किया कि, but also a bigger vision and an overall view of things. So it is quite remarkable. So well done, पूछ सकते हैं जी अपना पहले नाम बताइए और फिर सवाल।
अभी आपने कहा कि पाकिस्तान ने जो सक्सेसफुल हैंडलिंग की कोविड की उस पर यू यूज द वर्ड लक। आई वांट कि एक बड़ी इंपॉर्टेंट क्वालिटी में है हाइजेनिक थियरी। कैन यू रिलेट दिस टू दैट हाइजेनिक थियरी? द सेकंड क्वेश्चन इज द normal people, common people are asking nowadays where the vaccination stands now after this era of COVID. Thank you.
So, for those who don't know, Farooq and I spent 5 years in adjacent roll numbers. There's always a bad luck because the guy ahead of him was Farida Khan. I don't know आप उनको जानते हैं कि नहीं? वो भी हमारी क्लास थोड़ा लाइफ फाइट स्टार था. And then Farooq. So by the time my Viva came, the examiner was sick and tired of like people, and they said, "अच्छा जी, पास होना आपने बेटा मैं पास." So Farooq and I share a long. So Farooq मैं सरकारी. So I have a little limitation in the sense कि मैं आपको सरकारी फिगर आज की नहीं बता सकता. मैं हासिल कर सकता हूँ लेकिन मुनासिब नहीं होगा तुम जल्दी करो. जो मुझे लास्ट ऑफिशियली कम्युनिकेटेड थी वो मैं आपको बताता हूँ सितंबर की. उसमें 94% of the eligible population actually had vaccination. Or that was a number which at that point exceeded that of the United States.
Question ये होता है जिसने नहीं वैक्सीनेशन कराई हुई ना खत्म हो गया है. Should they go for vaccination or not? The question is this. Or it should be made a routine vaccination in future. ये question.
Look, I really don't know the answer other than to say one thing, which is that whenever the bivalent version arrives in Pakistan, if it is available to you, get it. Lekin I think most people in Pakistan have had 2 Chinese and perhaps a dose or 2 of Pfizer or mRNA vaccine. I think most people are in good shape so far. मगर मेरा ख्याल ये है कि जरा नजर रखनी पड़ेगी कि ये जो ट्रेंड्स हैं किस तरफ को जा रही हैं. The other thing you asked about was the hygiene theory or the lack of hygiene theory. I don't know. मैं इस पर कंजेक्चर ही कर सकता हूँ. मैं इसलिए ज़्यादा नहीं कहूँगा. I think that देखो किसी भी चीज़ में, but it's an important thing. So whenever you're setting out to explain something, कुछ चीज़ें तो known हैं. वो आपके सामने है, वाज़े हैं. ये चीज़ हुई, हमने ये वैक्सीन की, हमने स्मार्ट लॉकडाउन किए, हमने फलानी चीज़ की, ये किया, वो किया. सारी अच्छाइयाँ हैं, जो एक्शंस हैं उनके सपोजिड रिजल्ट्स हैं, आप उसके ऊपर कुछ बोल सकते हैं. हमेशा कुछ फैक्टर एक्स रह जाता है कि अच्छा इसके अलावा तो नहीं कोई चीज़. बिकॉज जब भी कोई आप मिसाल दे तो लोग कहते थे मगर उधर तो ऐसे हुआ. आपके वेदर को कहते हैं जी, मैं कहता था यूवी लाइट को कहते हैं जी, जरा यूवी लाइट से इंडिया में करता हो. तो एक चीज आपको बताऊं कि सबसे जो बड़ा चैलेंज था वो ये, आप नोट करें कि सबसे ज्यादा मुश्किल कहाँ पेश आई. लार्ज फेडरल स्ट्रक्चर कंट्रीज. अच्छा दूसरी तरफ से सोचिए किन मुल्कों में आपको क्राइसिस का पता चला? इंडिया, ब्राजील, यूएसए. कदर मुश्तरक क्या है? लार्ज फेडरल स्ट्रक्चर कंट्री. और फेडरल बड़ा मुल्क है तो नेचुरली फेडरल स्ट्रक्चर ये होगा ना, सेंट्रली तो रन नहीं हो सकता मासला कि आप चीन हो. सो जो डिसीजन मेकिंग थी ना वो इंडिविजुअल स्टेट्स को या प्रोविंसेस को गई. और हमारा भी हशर यही होना था क्योंकि वी आर अ फेयरली लार्ज कंट्री विद अ वेरी डिवॉल्व्ड हेल्थ स्ट्रक्चर. तो उसको रिकनेक्ट करना इनटू द फेडरल वाज परहैप्स वन मैजिक सॉस या मैजिक अननोन कह लें. Whether we were protected because of having had repeated exposures to other coronaviruses, possible. But I really don't have hard empiric evidence to support that. But yeah, it's a question.
Assalamualaikum sir, I myself Dr. Sajna. I am resident of Obs and Guidance at Gangaram Hospital. Sir, thank you so much for sharing COVID experience with us. I want to share my experience on behalf of my gynae unit. Sir, we were the first one to did C-section of COVID positive patient in our unit. And thank you so much for our professor, Professor Dr. Shamila Ijaz, because of her support and encouragement we did, and after that we all become COVID positive. Means our whole unit become COVID positive because of her support. We recovered well. Sir, my question is, last time we were run short of a lot of equipments. We didn't have oxygen masks, oxygen cylinders, ICU care for pregnant patients. Sir, my question is now we are well equipped to deal with any new outbreak or any new COVID outbreak, or still we are run short of ICU care and oxygen mask and all equipment? Any new policy you guys generated for us to deal with pregnant patients? They are all positive.
Your question को थोड़ा सा मैं इसको लार्जर कर देता हूँ आपके सवाल को. In other words, it's okay to be slapped once, but if you get slapped twice, shame on me, right? So I think what you're saying is कि एक दफा तो pandemic आई, whatever the challenges were there, have we learned anything and what have we institutionalized in terms of going forward? I think this is what you're trying to say. देखिए जो एक इंस्टीट्यूशनलाइजेशन जो थी बहुत अहम और जरूरी वो ये थी. मैं शुरू डॉक्टर अथर ने मुझसे सब सवाल पूछा कि 1-2 मिनट में बताएंगे सबसे अहम क्या एक्सपीरियंस था. एंड आई सेड सबसे अहम एक्सपीरियंस ये था the ability to get together in a room and being able to do mushawarat, consultation, logging your heads together, calling upon people for expertise or for action. इस चीज को इंस्टीट्यूशनलाइज करने के लिए नेशनल इंस्टीट्यूट ऑफ हेल्थ का जो कानून था उसको रिपोर्ट किया गया. उसके अंदर सेंटर फॉर डिजीज कंट्रोल बनाया गया ताकि हर दफा दौड़ के आपको एनसीओसी ना बनानी पड़े. एंड यू ईच टाइम यू कांट गो रनिंग टू द आर्मी कि आप हमें ये करके दें. द सिविलियन इंस्टीट्यूशंस हैव टू बी एबल टू डू दिस देमसेल्फ. तो एक तो ये इंस्टीट्यूशनाइजेशन है. लेकिन उसका नतीजा ये है या हो सकता है कि द काइंड ऑफ इनोवेटिव एंड आई टेल यू दैट अभी भी वो उन्होंने हमें डिटेल में बताया डॉक्टर साहब ने, लेकिन आपको एहसास कभी भी शायद इतने शिद्दत से ना हो कि द काइंड ऑफ लाइफ सेविंग वर्क दैट वाज डन जस्ट ऑन वन डोमेन ऑक्सीजन. और मैं अभी दूसरे डोमेन का जिक्र भी नहीं कर. तो आपको हर दफा ओके लेट मी पुट इट दिस वे, फॉर ईच न्यू स्ट्रगल, फॉर ईच न्यू चैलेंज उसकी अपनी डायनामिक्स और नीड्स होंगी. यहाँ ऑक्सीजन बिकेम अ नीड, ठीक है, आईसीयूज बिकेम अ नीड, मे बी डिफरेंट खुदा न खास्ता है फ्यूचर पेंडेमिक. तो जो चीज आपने इंस्टीट्यूशनलाइज करनी है वो ये नहीं करनी कि आखिरी you do not respond to the last slap using my slap वाली experience. You have to be prepared for all sorts of slaps. So therefore आपके सिस्टम के अंदर काबिलियत होनी चाहिए of learning from data and adjusting and responding to it. So stockpiling, expanding of services, teaching and retooling your staff, making sure that you can actually re-engineer some of your production facilities. आपको मास्क की कमी eventually क्यों नहीं पेश आई? Because your local industry, including the cotton industry, actually readjusted themselves to making enough masks. शुरू में आपको याद है मिलते नहीं थे, बाद में रोल भी पड़ी गई थी. So I think that is the institutionalization of things. एक चीज जो हमें अभी शायद हमने नहीं की और हमें उसको उससे भी ज्यादा जरूर करने की जरूरत है is ensuring the connectivity. जो डेटा था ना जब यहाँ से जाता था प्रोविंसेस से, तो फॉर एग्जांपल पंजाब और सिंध के अपने अपने डेटा सिस्टम्स थे. इनको व्हाट आर कॉल्ड एपीआई इंटरफेसेस हैं, कंप्यूटर के इंटरफेसेस हैं जो एक सिस्टम को दूसरे से बात कराते हैं. तो वो उनके जरिए ट्रांसफर होता था. इस्लामाबाद जीबी वगैरह डायरेक्टली इंपोर्ट करते थे सिस्टम के अंदर. तो ये जो इंफॉर्मेशन सिस्टम्स की फ्लो और उसकी बैकबोन को पक्का करना है वो मुझे नहीं मालूम कभी तक हुआ है, लेकिन जो फ्यूचर या प्रेजेंट सीडीसी है उसकी जॉब में ये शामिल है टू एक्चुअली एंश्योर दैट दिस हैपेंस एंड यू नेवर आर शॉर्ट ऑफ an important commodity. But again याद रखिए हर नई पैंडेमिक अपने साथ एक नया और फर्क चैलेंज लेके आती है और उसके साथ एडजस्ट करना और मुतहर्रिक करना. You have to be agile to make your decision making. So that is the part that needs institutionalization. I hope I've answered you. थोड़ा long winded सा जवाब था, but आपने तरीका कार जो करना है उसको इंस्टीट्यूशनलाइज करना. हर दफा वही वाला आले वाला हाथ नहीं चलेगा. इस दफा ऑक्सीजन थी या मास्क थे, हो सकता है कि दफा चैलेंज कुछ और हो.
जी बहुत एक सवाल
डॉक्टर सुल्तान ने बहुत कॉम्प्रिहेंसिव जवाब दिया और एक नेशनल स्ट्रेटजी. बच्ची का क्वेश्चन था रिलेटेड टू स्पेसिफिकली द गंगाराम हॉस्पिटल एंड द गायनी पेशेंट. आई हैड द एक्सपीरियंस इन व्यू, और व्यू में मुझे 12 जून 2020 वो दिन मुझे याद है कि जब व्यू में 410 पेशेंट और हमारे पास टोटल कैपेसिटी 426 की थी. एक्सपैंड करते गए 426 पे सैचुरेट हो. और रात में मुझे याद है कि जब 10 बजे प्रेसिडेंट डॉक्टर यास्मीन राशिद का टेलीफोन आया कि 410 पेशेंट हो चुके हैं एंड वी आर नॉट गोइंग टू रिफ्यूज एनी पेशेंट, गो टू यकी गेट और 100 पेशेंट जो बेड्स हैं वो एक्सपेंड करके एक रात आसफ तुफैल में गए और 100 बेड हमने ऐड किया और फिर रिपोर्ट कर दी. So as far as Lahore facility and dashboard, they were things keep on expanding. जहाँ तक गायनी के exclusive patient का ताल्लुक है, they were not refused in Lady Exeter or Lady Linden. लेकिन जो specific hospital designate किया गया, that was the Gangara Hospital. And I think I must give credit to all the department of gynae and you people also. कि आप लोगों ने with perception you try to manage. लेकिन पूरे लाहौर के गायनी के पेशेंट आए थे एक अस्पताल में एंड दैट वाज द गंगाराम, और बाकी तमाम पॉजिटिव जा रहे थे, तमाम फ्रेशली केयर थे. दैट इज व्हाई आप पे जो डिजीज बर्डन था वो रिलेटिवली ज्यादा एंड यू फेस दैट आई थिंक विद परफेक्शन. लेकिन अब फ्यूचर स्ट्रेटजी के तौर पे चूंकि गंगाराम एक मशहूर है, ये गायनी का हॉस्पिटल है एंड आई थिंक वी मस्ट गिव क्रेडिट टू प्रोफेसर डॉक्टर यास्मीन राशिद एंड द करंट गवर्नमेंट कि एमसीएच इस पर फंक्शनिंग है. इसकी फ्यूचर कैपेसिटी 600 की है और 200 बेड्स के साथ इसका तुम्हारी यूनिवर्सिटी फंक्शनिंग है. खुदा ना खास्ता अगर दोबारा कोई ऐसा एक्सपीरियंस होता है, गंगाराम विल बी फुली प्रिपेयर्ड इंशाल्लाह.
जी एक मिनट, आपसे पहले एक और सवाल, सॉरी नवीन से मैं पूछना चाहता हूँ सवाल, अगर आप बताएं आपका तजुर्बा जो था वो प्रेग्नेंट पेशेंट्स के साथ और चाइल्ड बर्थ के दौरान क्या था. वहाँ पे इंग्लैंड में ये प्रॉब्लम थी कि जो वैक्सीन अपटेक रेट था वो पाकिस्तानी मरीजों में कम था सैडली, एंड देयर वाज एक्चुअली अ मोर्टेलिटी इन वेगन जहाँ पे कि जब वाद हमारा ट्रांसफर मेडिकल डायरेक्टर है इन अ यंग वुमन वाज गिविंग बर्थ टू द पाकिस्तानी बिकॉज़ शी हैड नॉट बीन वैक्सीनेटेड. तो आपका क्या एक्सपीरियंस था लाहौर में?
उसके एक्सपीरियंस में ये कहूँगी हमारे पास जैसे सर ने कहा कि वी वर रनिंग टेकिंग पेशेंट्स फ्रॉम ऑल ओवर द पूरे पंजाब से बल्कि हमारे पास आ रहे थे. मोस्ट ऑफ द पेशेंट दे वर नॉट वैक्सीनेटेड. जो हम लोग रिसीव करते थे प्रेग्नेंट लेडीज, उस वक्त वो वैक्सीनेटेड नहीं थी, स्पेशली द फर्स्ट डे. और मॉर्टेलिटी उसमें हमारी बहुत ज़्यादा थी क्योंकि प्रेग्नेंट लेडीज विद कोविड उसमें मॉर्टेलिटी वी एक्सपीरियंस लॉट ऑफ यंग डेथ्स जो हम अभी तक नहीं भूल गए. लेकिन अब सिचुएशन डिफरेंट है, लोग अब वैक्सीनेटेड हैं. जैसे सर ने बताया 94% more than 90% of the population is vaccinated. उस वक्त कोई एक्सपीरियंस और एक्सपीरियंस बहुत अच्छा नहीं था रिगार्डिंग मॉर्टेलिटी बहुत ज़्यादा.
थैंक यू. होपफुली दिस हैज बीन रेमेडिड. जी आप फरमाइए.
अस्सलाम वालेकुम जी, मैं प्रोफेसर आमिर गुट्टा हूँ और आई एम सो कॉल्ड FGI फॉर 25 years एंड सो कॉल्ड कैम्पोलियन फॉर 8 years, क्योंकि दोनों का मैं स्टूडेंट नहीं हूँ. मैं सबसे पहले आपको सल्यूट करता हूँ जो आपने सर्विस कोविड के दौरान दी, और क्योंकि आपको आज आया नहीं कि आप सामने बैठे हुए. आपसे एक एक्सपीरियंस शेयर मैं करना चाहता हूँ. बिकॉज फ्रॉम अमेरिका टू जापान एवरी हाउस इज इन नाइटमेयर. मेरा बेटा कोविड का इंचार्ज था जना हॉस्पिटल वार्ड का, और थ्रू आउट वो जना हॉस्पिटल कोविड का इंचार्ज ही रहा. तो अल्लाह के फजल से हम सारे बच्चे रहे क्योंकि हम वी आर एवरी हाई रिस्क थे. तो वो घर पे आता था तो सेट पे खड़े होकर शॉट करना, एवरीबॉडी इन द रूम्स लॉक देमसेल्फ और सारे कपड़े उतार देना, देन गो टू द वॉशरूम पर 15 मिनट शावर लेना गर्म पानी से, फिर मां ने उसके कपड़े वहां रखे होते थे, चेंज करके फिर उसने कहा लो कम आउट, एवरीबॉडी कम आउट, और हम बैठ जाते थे. तो अल्लाह के फजल से बच्चे, लेकिन जब एवरीथिंग वाज फाइन खत्म हो गया तो दोनों मियां बीवी को कोविड हो गया. परेशान अब क्या हो गया, बीवी उसके DMS नाम है. तो हमने कहा इनको क्या हो गया, 10 दिन तक वो फिर अपने कमरे में बंद रहे और 10 दिन से अल्लाह और फोन पे ही अपने प्रोफेसर से ट्रीटमेंट लेते रहे. लेकिन अल्लाह की मदद से अब ठीक हो गए, बैक टू ड्यूटी. थैंक यू वेरी मच.
Sorry, my name is Dr. Faisal Khan. I am Registrar of Pulmonology and Critical Care Department, Gangara Hospital, and I have been working here for the last 3 years. I have also worked in the COVID pandemic. I have few queries regarding the COVID management. There are many experts here sitting around us. मैं आपको easy लैंग्वेज में बता रहा हूँ. जब कोविड की मैनेजमेंट है, ऑक्सीजन रिक्वायरमेंट के हिसाब से स्टेप अप बेस करते हैं उसको और उसकी मैनेजमेंट उस हिसाब से चेंज होती है। इनिशियली पेशेंट कम विद मिनिमल ऑक्सीजन रिक्वायरमेंट जो कि नेजल कैनुला पे हम पेशेंट को डाल देते हैं। उसके बाद हम ऑक्सीजन मास्क पे शिफ्ट आउट करते हैं। जब उसकी 15 लीटर के करीब ऑक्सीजन रिक्वायरमेंट हो जाती है, 10 से ज़्यादा होती है, तो उसको एनआरबीएम पे शिफ्ट कर देते हैं। तो एनआरबीएम से अगला स्टेप क्या होता है, सीपैप, जो कि वेंटिलेटर के थ्रू हम उसको अप्लाई करते हैं 100% FiO2 में। जो पेशेंट सीपैप पे भी टॉलरेट नहीं करते, लाइक व्हाट आई हैव सीन, उन पेशेंट को मोस्ट ऑफ द डॉक्टर्स क्या करते हैं कि लाइक प्री ऑक्सीडेशन करने लग जाते थे before ventilation, like that they shift back to the ambu mask with 40 liters of oxygen, which is basically initial wrong concept of pre-oxidation of a patient who is already on CPAP with 100% FiO2, which is more than 14 liters of oxygen. फर्स्ट स्टेप एक तो क्वेरी ये है, दूसरी क्वेरी ये है कि उसके बाद जब हम पेशेंट को वेंटिलेट कर देते हैं तो देयर आर मेनी मोड्स which help out for the patient. The most effective which I found there, like it is the PRVC mode, pressure regulatory volume control mode, जिसमें पेशेंट के पीक प्रेशर कंट्रोल में रहते हैं। अगर उसके अलावा किसी इनिशियल दूसरे मोड में हम डालते हैं पेशेंट को तो उसको टाइटल से डिलीवर नहीं होते हैं, उसका लंग इतना मुतासिर हुआ होता है कि उसको ऑक्सीजनेशन ही नहीं मिलती और वो विद इन फ्यू सेकंड्स कोलैप्स कर जाता है।
Thank you, Beta. I think you have very eloquently expressed your clinical experience, which is very valuable. I would suggest कि आप तुफैल से मिले बाद में, जो कि बहुत एक्सपीरियंस है एक्टिव केयर में। शम्सा, आपका एक सवाल था।
सर मेरा I just wanted to respond about our experience at Bangara and Fatma nurses. We were like the center of excellence for the management of obstetrics and gynae patient. जैसे नौरीन ने बताया कि मोर्टेलिटी बहुत ज़्यादा थी, तो प्रोबेबली द रीज़न वाज इतना स्केरी था और इतना लोग अवॉइड कर रहे थे, देयर वाज डिले इन द ट्रीटमेंट। पेशेंट्स हमारे पास सारे पंजाब से आ रहे थे और द मोमेंट DHQ में प्राइवेट सेटअप में पता चलता था द पेशेंट इज हैविंग सिम्टम्स, मे बी कोविड और मे नॉट बी, so people they refuse to touch them. इतना ज़्यादा उस वक्त था। और then I would like to appreciate the efforts of gynae department, anesthesia department, ICU, administration. It was a teamwork. Without the teamwork, it would not have been possible for us. और जैसे हमारी लड़कियां थी, the moment patients came और जिस तरह से इन्होंने उस वक्त केयर की, the shortage of supplies, मास्क नहीं थे, PPEs नहीं थी, so that is life long experience. मेरा ख्याल जिन लोगों ने वहाँ उस वक्त काम किया, probably they learned a lot. और obstetrics patient जैसे बच्चा था, उस वक्त ये नहीं था कि आपने, इसमें मैं नर्सिंग स्टाफ को भी कहूँ, our nurses, paramedics, everyone was on board and everyone was motivated, and probably they did wonders for saving many lives during COVID.
Thank you. I think we are coming to the end of this session. तो मैं आपसे ही 3 सवाल पूछूंगा बारी-बारी, starting from Hamid, और उसके बाद we will conclude. लेकिन there will be a pleasant surprise for you, जो कि non-medical होगा। उसके बाद मेरा ख्याल है कुछ ceremonial चीजें भी हैं जो बाकी हैं। तो हामिद, आपसे मैं पूछना चाहूँगा, आपसे एक ही सवाल है तीनों से, लेकिन क्योंकि आपका डोमेन फर्क है तो आई थिंक इट बी यूजफुल टू आस्क। ये बताइए कि जो लेगेसी ऑफ कोविड क्या है, इज देयर अ डिविडेंड जो कि हम यूज कर सकते हैं और चीज़ों में? मसलन आपने जो एक्सपर्टीज रिक्वायर की इस पैंडेमिक और क्राइसिस सिचुएशन को मैनेज करते हुए, क्या वो आइंदा के लिए या किसी और डोमेन में इस्तेमाल हो सकती है? हमें
मेरे ख्याल में ये बहुत अच्छा एक्सपीरियंस लर्निंग के लिए कैसे नेशनल इश्यूज और डिजास्टर्स को सॉल्व कैसे कर सकते हैं। एंड वी वर हैविंग वेरी डिफिकल्ट टाइम जब हमने बनाई थी नेशनल क्राइसिस मॉनिटरिंग कमेटी, शौकत रिंग साहब उसको हेड किया, उसमें वी यूज्ड टू गेट दिस नॉन कोऑपरेशन प्रोविंसेस की और सारा। लेकिन ये जब एक्सपीरियंस हो गया है और जब हम लोग प्रोविंशियल गवर्नमेंट्स के साथ जो डिफरेंट पार्टीज की थी, उनको जब आप इकट्ठा बिठाते थे NBMC मीटिंग में, तो देयर रिस्पॉन्स वाज एक पहले से रेपुटेशन एक ऐसी बन गई थी कि हाँ ये बैठ के मसले हल किए जा सकते हैं। शुड आई स्टॉप और जो भी मुसीबत आती है एक अपॉर्चुनिटी भी होती है और कुछ चीज़ें जो है वो हमें डायरेक्ट लर्निंग है, कुछ इसके बुरे असरात भी आए।
Thank you very much. आप distinguished panel का और distinguished audience सबका बहुत बहुत शुक्रिया. This concludes the medical component. Now for some light. तो ये रस्म है जो कि हमारी जवानी में बहुत कारआमद हुआ करती थी, लेकिन और हामिद की जवानी में भी अगर चाहिए हमारे मुकाबले में कम उम्र है, तो इन्होंने इसको रीराइट किया है अपनी इस किताब में। तो जो रीराइटिंग है वो इतनी रोमांटिक तो नहीं है, लेकिन आप खुद ही सुन लीजिए। हामिद
ये चाहते हैं कि मेरी इज्जत और बेइज्जती दोनों ये 18वीं में जाना तो 1.5 ओवर की शायरी है, सारी की सारी। तो इसमें एक ऑर्थोपेडिक का शेर भी लिखा हुआ मैंने कि अब तो सीधी नहीं होती कभी मुड़ जाए जो टांग, अब तो सीधी नहीं होती कभी मुड़ जाए जो टांग, मुझसे पहली सी मोहब्बत मेरे महबूब है। अब जैसा हमने लिखी थी मोहब्बत की पहली नज़म, तो मैंने लिखी है मोहब्बत की आखिरी नज़म कि अगर कभी मेरी याद आए, अगर कभी मेरी याद आए तो साहिलों पर लगे दरख्तों के शाख पत्तों में नारियत को तलाश करना। अगर वो शाखे शजर से उड़ के तुम्हारे सर पे टपक पड़े तो ये जान लेना कि भाई न्यूटन ने जो कहा था गलत नहीं। अगर ना आए, मगर ये मुमकिन ही किस तरह है कि तुम किसी पे निगाह डालो तो उस बेचारे का दिल न डूबे, वो अपनी मस्ती न भूल जाए। और अगर कभी मेरी याद आए तो घर के रास्ते में आने वाली बड़ी दुकानों की बेसमेंटों में देख लेना, वो चौथी लाइन के शीशे वाले बड़े फ्रीजर की टॉप शेल्फों पे गौर करना, दही के डब्बे के साथ बैठा तुम्हें मिलूंगा। अगर कभी मेरी याद आए तो घर के रास्ते में आने वाली बड़ी दुकानों की बेसमेंटों में देख लेना, वो चौथी लाइन के शीशे वाले बड़े फ्रीजर की टॉप शेल्फों पे गौर करना, दही के डब्बे के साथ बैठा तुम्हें मिलूंगा। और तुम्हारी यादों के आसमान के उफक से डूबा मैं अपनी दफ्तर की फाइलों में तुलू होकर वहीं पे फाइल के साथ फीते में बंद गया हूँ। किसी सियाने रिकॉर्ड कीपर से पूछ लेना, वहीं पे हूँगा। और अगर दरख्तों पे, फाइलों में, फ्रीजरों में न पाओ मुझको तो जान लेना तुम्हारे डर से किसी अजीबो गरीब गोशे में छुप गया हूँ। रिपोर्ट करने जो घर से निकलो तो बेड के नीचे भी देख लेना।
और तविंदा से तमाम गेस्ट का भी बहुत शुक्रिया। एकेडमिक काउंसिल मेरी 90% मौजूद है, फाइनल स्टूडेंट सारे मौजूद हैं, सबका बहुत शुक्रिया। और PMA को रिप्रेजेंट कर रहे हैं अशरफ निज़ामी साहब, उनका शुक्रिया। और इस वक्त कोविड का ये सेमिनार है, तो मुझे याद आ रहे हैं डॉक्टर तारिक शफी और डॉक्टर बरदा।
Thank you very much. मुझे कुछ बात करने का मौका देने का। I did want to say something and मैं कुछ अपने पर्सनल एक्सपीरियंसेस शेयर करना चाहूँगी। जैसे जब कोविड आया था, it was March 20 और किसी को मालूम नहीं था कि PPE क्या चीज़ है। और I still remember that fear that I felt जब मैं हम लोग का आइसोलेशन वार्ड था उसमें मैं गई और मैंने नर्स से पूछा how am I going to go into this room? तो उसने मुझे कहा वो किट पड़ी है पहन लो। मैंने कहा shoe covers, she said no shoe covers. And this is how it all started. And then we would see patients coming in slightly breathless, then becoming more dependent on oxygen, and then passing away. And this is the helplessness cycle that we saw. And you know, people like me, जो कि अपने करियर के आखिरी एक तिहाई हिस्से में है, उनके ऊपर बहुत असर पड़ा। मेरे दिमाग पे तो कम से कम बहुत असर हुआ। It has changed me forever. It has actually situation made me realize how helpless we are as doctors and how helpless I was as a human being, not being able to help anyone. और जो मेरी तरबियत थी ये holding a patient's hand when they are in discomfort, we couldn't do that. We could not go near these patients, we couldn't touch them properly, कुछ नहीं कर पाते थे उनके लिए. So in that situation, you know, I actually salute Faisal because he must have gone through all that fear in those decisions that he was taking, and he has made those, and you know, fortune favors the bold. He must have taken some bold decision. He must have done that, and you know, I really appreciate it. He must have been traumatized like I would have been, and you know, coming out like this and talking like that, you know, really, I really thank you. And for Professor Godel, I have a couple of words to say. I was joking with Athar कि हम मुसलमान हैं तो हमारा किबला पहले जो था बैतुल मक़दस था और हम उस तरफ नमाज करके पढ़ते थे और फिर हमारा खाना काबा हो गया तो हमने उस तरफ मुँह कर लिया तो हम एफजे में आ गए उनके साथ पीछे उनके. So we have he has always been so supportive, and all the things that we always suggested that we wanted to collaborate with, he has never said no to us. And this is why we are here today. And Dr. Fail, I do remember the cold mornings that he used to wake up at 6 और अक्सर मैं meetings में मिस हो जाती थी. ये सारी जो हम लोगों की होती थी common meetings होती थी Saturday morning को. Dr. Fail used to be going for board rounds and he would say मैं on call हूँ मैं जा रहा हूँ, but he was always there. So you know, I want to clap for and all of us, you know, including Hamid. It really brightens me and makes.
Thank you very much, Tabitha. और अब सबके और तबिता के किबला कबर नाम बदल साहब. जनाब आप अगर कोई हुक्म इरशाद फरमाना चाहें.
Among research posters, cardiovascular health. Awareness posters, it was dissociative identity disorders, made by 4th year students, batch C1. So I congratulate all the winners and thank you Dr. Azra and Dr. Alia. और मैं सर से रिक्वेस्ट करूँगी कि सर आपने मेरी रिक्वेस्ट है आपने 3 प्राइजेस अनाउंस किए थे मुझे यहाँ 4 विनर्स कर दीजिए अगर हम जैसे आप
ऐसे करें जो आपकी कमेटी डिसाइड करेगी हम चारों को प्राइज देंगे. अभी सर स्पीकर्स के वो जो शीट दे रहे और फैसल साहब ने भी जाने आफ्टर 5 मिनट विल कंक्लूड. लेकिन ये तमाम बच्चे अपने लंच बॉक्सेस जरूर लेके जाइएगा और जस्ट खाना खा के जाइएगा.
From each session, please take their sheets. The speaker that was left for the first session, critical care professor will be sheets. The panel certificate was to give the sheets to the. Next sheet is for Dr. Varda Shetty. Next sheet is for Dr. Varda Shetty. Next sheet is for Dr. Ganpati. Dr. Tariq Gohar. Professor Ashraf Nizami. Then, for panelists of this session, Dr. Hamid Khatib. Dr. Abdullah Abdul. She is for the chairs of the session. The first sheet is for Professor Louisa Begum.
Dr. Mohammed Tufail. Dr. Afsar. Dr. Kamal Masheen. Give the sheet to Professor Dr. Khalid Usman.
अब मैंने सिर्फ अदर साहब से इतना पूछना है, अदर अहमद सही, जो इन बच्चियों का आपने देखा है जोश आपको शील्ड देने में, किंग एडवर्ड का रिकॉर्ड करके आपने भेजना है कि ऐसे ही नहीं हो सकता ना। Having lunch for the guests in the ground और आपके lunch boxes और इंशाल्लाह we will again get together for next 2 days 19th and 20th 19th and 20th. Thank you and thank you very much.